Welcome to the respiratory system. So this is basically my second favorite system that we have because it goes hand in hand with what it is that the cardiac system does, and you will see shortly how it is that works. So we have structures that are divided into the upper airway and the lower airway. So upper airway is going to be anything that's above the glottis, which is the opening of the trachea. And then below that is the lower airway, which is going to include the lungs themselves, and then the structures that are within the lungs, which are the bronchi, the bronchioles, and the alveoli. And so the whole point of having a respiratory system is that it's how you get air in, right, which has oxygen in it, which is what we absolutely need. And then it's also where carbon dioxide will go from the blood into the alveoli and then leave. So it does what is called respiration. And respiration is basically gas exchange. So external respiration takes place from the blood into the lungs, and then from the lungs into the alveoli, into the blood. And then internal is going to be from the blood to the tissue, and then from the tissue into the blood. So as we go through this, we'll go through and get into little specific examples about that, and I'll try to be as clear as possible with it. So when you look at your airways, right, here's the glottis, the opening to the trachea. Everything up here, so your nose, your mouth, and then this portion of the larynx, that is all considered the upper airway. And then below hand, this is going to be your trachea. It branches off into the main or primary bronchi, and then it breaks off into secondary, and then tertiary, and then it just gets smaller and smaller. Then you'll note that the diaphragm here is what separates the thoracic cavity from the abdominal cavity. When we get down into the actual microscopic structures, you'll see this, and what you're looking at here are the alveoli, which are the little air sacs. You've got bronchioles that connect directly into the alveoli, and then surrounding the alveoli are the capillary networks that end up bringing carbon dioxide blood to the alveoli so that you will exhale it, and then bring in the oxygen-rich blood from the heart into the alveoli, or the oxygen-rich blood will then leave the alveoli and then go back to the heart. So we have what's called ventilation. So pulmonary ventilation is just the movement of air, breathing air in and out. The external respiration, again, is the oxygen and carbon dioxide exchange between the alveoli and the blood, and then it's going to get transported through the blood to the respective tissues throughout our body, and that is where they undergo internal respiration, which is when the oxygen unloads from the blood into the tissue, and then carbon dioxide from the tissues will then load into the blood, and then that is where you have the internal exchange takes place. So external respiration, just remember it's going to be from the lungs and the blood, and then internal is in the tissues, easy way to remember that, and it's between the blood and the actual tissue cells. Our pharynx is divided into three different subdivisions, which are the nasopharynx, the oropharynx, and the laryngopharynx. So when you think of pharynx, most of the time people think about this tube, right? And they think of it as just the throat. But your pharynx actually originates in the back behind the nose. So here's where your nose is. You inhale air through here. These are your nasal passages, and they are lined with membranes, which are the mucous membranes. And then you have these little gaps in between. These are called conae. And what they do, or meatus, and they actually protect the conae from a bone that's called the ethmoid. And the air comes in here, and the whole point of the nose is to warm and humidify the air. Then it comes in through the back, and then will travel down into the actual trachea. So this is your epiglottis right here. And when your epiglottis is up, right, when it's vertical, that means that the glottis, the opening for the trachea, is open. It's able to allow air to come in. When you swallow with your tongue, what it does is it actually pushes back on the epiglottis, and then that covers this gap, and it prevents air, or it prevents fluid and food from being aspirated into the actual glottis. If at some point, we've all done this, you've been drinking something or eating something, and you accidentally get something here on your glottis, you will very quickly do this explosive coughing that sometimes can spray the whole mirror, right, with your coffee or drink or whatever you had. And because you don't want ever to get anything into the trachea, because obviously that's going to lead down into the lungs. So our pharynx is divided into the nasopharynx, the oropharynx, which is just the back part of the mouth, which is what we normally call the throat, and then the laryngopharynx, which is then the posterior part here behind the epiglottis. So nasopharynx, just remember that is where your nasal passages are. Key thing to remember that I'm going to ask you about is that the whole point of the nose and that nasopharynx pathway is going to be to warm, filter, and humidify the air, and that is also obviously where we have the olfactory receptors. When you look at that posterior portion of where the nasopharynx is, it's going to meet up with that soft palate, and then the uvula is that little thing that just kind of flap that hangs down back of your throat. You can actually see it, and it just separates it into left and right. And then in the posterior part of the nasopharynx, that is also where you have the pharyngeal tonsils on the posterior portion, and then they're located there obviously as part of your immune system. And then we also have these little auditory tubes that dip down into the actual space that's going to drip down here. So here are the pharyngeal tonsils. Obviously here are the passageways, right? The nasopharynx is going to pass through. These are the mucous membranes. And then this piece right here, this is your uvula. And so the nasopharynx portion also contains that little tube, the pharyngotympanic tube. And this is where you actually have, it's connected to the ear. So if you ever get eardrops and then they drip down here into this tube, sometimes they drip down back here and you can actually taste the yuckiness. Usually they're pretty bitter on the back part of your tongue. But the whole point of having this little opening is to help equalize the pressure in your ears by being able to use the nasopharynx and the oropharynx for that. Then the warming in air, right? Obviously very important. If you've ever lived anywhere really cold and you try to take a deep breath when it's really cold out, it actually causes the glottis to spasm and close because you don't want to get really cold, bitter air down into the lungs. So that's why sometimes that happens, and sometimes also why you're actually going to end up coughing. And then you also have, like I said, the olfactory receptors. Then our nostrils, their proper name is actually nares. So we have the external nares, and then we have some little internal nares that are more posterior, that are part of that opening of the nasopharynx into the pharynx. And why this matters is because you are going to learn how to intubate somebody through the nose. They actually have to be conscious when you're doing that. But when you do a nasal intubation, it actually works really well because it actually helps guide that portion of the tube to then go down into the actual trachea. And what you're doing when you intubate somebody through the nose is you're actually bypassing that oral portion where there would be a gag reflex in the individual. But the person has to actually be able to sit up as you're doing this, and they have to be conscious. So here's a nose, obviously. So this is this part up here where the bones are. These are the nasal bones. The rest of the nose itself is actually all cartilage. So if we take off the skin, then you can see basically where the actual nose portion is with the bone, and then all of this here is going to be your cartilage. So this can also obviously be broken when somebody gets punched in the face. Then nasal mucosa, again, real important for that. One, they have a lot of mucous membranes to help protect you somewhat from getting infected with colds and flus and stuff like that. But as you know, it doesn't 100% of the time work. But again, the whole main point of that is to help filter and heat and moisten that air. And then what you're looking at here, this is a cadaver, so it's a sagittal view of a cadaver. And what's pretty cool is you can actually see really well where it is where the nostrils are located. So as the nose, right, in comes through the nose, so this is going to be that opening of the nostril, comes in, and you would pass, when you're doing that nasal intubation, you pass that tube through these nasal passageways. And again, these are pretty vascular, so one of the things that you're going to do when you do that is you'll actually spray the nose with a substance to actually minimize the bleeding. And then you'll pass the tube through the posterior portion. This is where the uvula is located, and then be passing it through, and then it'll actually direct into the actual trachea. So you'll be able to bypass that portion here of the epiglottis, and so it doesn't end up triggering that gag reflex in the patient. Posterior here to the trachea, this is where the esophagus is. It's a pretty thick muscular tube, so obviously this is why when we swallow food, it's going to go into this area, and then it moves down through peristalsis into our stomach. And then this right here is where our tongue is located. This is the lingual tonsil, and then up here at the top towards the backside, this is where you would see the actual pharyngeal tonsil, and then the other tonsils that we have, the palatine tonsils, those are going to be located up here. And so up in this region here is where you would have more of that tonsil to help protect you from bacteria and viruses and all the stuff that can get in. Then the trachea itself is actually lined with this pseudostratified columnar epithelium, and it's ciliated because you don't want stuff getting in there that we can't get out. And so when the trachea actually has stuff in it, you have mucous membranes, right? So you're going to have mucus glands in here that will then basically secrete mucus into the space, and then it helps you get rid of stuff. These cells right here, these little white ones, these are goblet cells. They also secrete mucus. And the whole point of having this type of tissue along the trachea and the bronchi is so that it is protective. And what it does is it helps protect that trachea from having stuff that is not supposed to go down, which should just be air, from getting into that space. Then on the anterior portion of our face, we do have sinuses. So these are called the frontal sinuses. And then we have some ethmoid and then what we call the sphenoid sinuses, and then the maxillary sinuses. And the whole point of having sinuses is you have membranes around them. Yes, they can get infected and cause sinus infections, but the whole point of it is to help lighten the skull, because there is so much bone on the actual skull and then also on the anterior portion in the face. Then the sphenoid sinus, this right here, this is at the posterior portion. I just want to point this out. This is part of this bone called the sphenoid. And what it is that in this little gap right here, this is called the sella turcica. This is where your pituitary gland sits, and your hypothalamus is actually located right up here. And so your pituitary gland is actually protected really, really well. And then what's interesting is this portion up here, your eyes are actually up here, right? And so your optic nerve passes through here, and then it actually crosses at this point just above where that pituitary gland is housed, and then can go to the opposite side. So just kind of interesting stuff that you see when you look at this sagittally. Then the oropharynx is going to be the point from the uvula to midway through that epiglottis, and that is where air can also enter. Obviously, it can come in more rapidly and directly because there are no membranes and no little kind of tunnels, those meatuses that kind of slow down the air as it passes through. It's going to be much less moist because you don't have as much moisture of mucous membrane type material that is passing through in the mouth. And then it'll go posterior, past the epiglottis, and then down into the actual trachea. So this is obviously your mouth. Open it up and air can come in. And then here we have the palatine tonsil and then the lingual tonsil in the back. But when you breathe in through your mouth, it's going to come through and then go into the larynx. And of course, again, that epiglottis is going to be upright so that the opening into the larynx, which is called the glottis, is open for you to be able to breathe in air. When you speak, air is going to be obviously coming out, and then what it does is it vibrates the vocal cords located in the glottis area just above, and then that is how sound passes through. Then your laryngopharynx, that's just the region where air and food will pass through posterior to that epiglottis, and then this is where you'll have that region here. So all of this right here, this is where that laryngopharynx is located. And so this is going to be the spot where when someone is actually choking, right, they've got something stuck here, that is where it usually ends up being stuck. Or if it drops down a little bit, then it could be stuck in here. And so this is why when we do that Heimlich maneuver, what you're doing is you're actually creating positive pressure in the abdomen to then force air up, right? So you're pushing up against that diaphragm to then force air up through the airway and then try and get that chunk of whatever it is out. Then posterior here again, this is the esophagus. So one thing that you'll note when you're learning how to intubate, what you're going to be doing is you're actually looking for the epiglottis. And there is this little ligament right here that is called the hyoepiglottic ligament. I'm going to show you that in a little bit. And this is what you're aiming for with your blade. And so what it's going to do is when you pop the blade onto here, it actually lifts the epiglottis out of the way and really gives you a good view of that opening of the glottis. Because what happens often as you're very first learning how to intubate, and you'll see this when you go to cadaver lab, is that the tube, when you're intubating, often will keep going because it's much easier to keep pushing to the back and get into the esophagus. And so then how you'll know that you've intubated the wrong spot is you'll actually have gastric bubbling sounds when you constrict the bag, the ambu bag, and your air is actually going into the stomach and not into the lungs. When it goes into the lungs, it should feel almost like little feathers when you're listening to the lung sounds. Then the lower airway again, this is going to be below the glottis. So it's going to be that portion of where the trachea begins, and then it's going to break off and branch into the primary, or what's called main stem bronchi, then secondary, tertiary, so it just starts branching off much like you see with the tree. And then eventually you'll get down to the bronchioles, which are little tubes that are surrounded by smooth muscle. and then it gets into this little alveolar duct and then directly into the alveoli. So as we work our way down, now we're in the lower airway. That's anything below that portion of the glottis. So when we break it down further, as you look down and you get into the actual trachea, you'll note that this is it. We've got one tube, it's a pretty good sized tube, to get the air into both of our lungs. The right lung is going to have the primary bronchi, or the main stem bronchi, is actually a little bit more vertical. And what happens is that sometimes when you're actually intubating somebody, it is very common to actually sometimes end up here in that right main stem bronchi. And so what will happen, and how you'll know, is that you'll hear lung sounds on the right, but you will not hear them on the left. And so what you have to do then is you actually have to deflate the cuff and then pull the tube up a little bit so that it actually ends up here in the actual trachea. And then here you can clearly see as well that the trachea will branch, and the point at where it branches is this cartilage here that's called the carina. To me it looks like little tighty-whities or little underoos. You know, little kids wear little underwear. And then from here is where your right and your left main stem bronchi are. And then these right main stem bronchi will branch into secondary, then tertiary, then quaternary, and they just get smaller and smaller and smaller. And so what you're feeling all along here are going to be cartilages that are actually keeping these tubes open. Once we get into that microscopic anatomy where you can't see it anymore or feel it, now you're actually getting into the bronchioles, which are softer tubes that are now surrounded by the actual smooth muscle. So when you get into the actual larynx, this is the part where obviously is where the air is going to go into so that it can then get to the lungs. And so what you're looking at here is we're going to have some significant cartilages that are going to be very important for you to learn and understand when you're learning how to do a cricothyroid procedure, which means something's happened above that glottis, right? So either the face has been practically blown off, or there's a lot of, edema in the throat, so you actually can't get a tube down there. So that's when you're going to have to do this cut. And so this is just a diagram of it. And so what you're looking at here, this is the hyoid bone. Here's the epiglottis, just posterior to that. Then you've got this thick membrane here. That is not the one that you're going to be putting in a blade into. This right here is your thyroid cartilage. All right. This thyroid cartilage is what we would refer to, right, as the Adam's apple. It's not as prominent in females as it is in males. And what you're looking for is this cartilage first. And so you'll find this spot that kind of sticks out. It's a little bit of a protuberance and it's hard. Just below that, it kind of drops off. All right. And then here you have that cricothyroid membrane. All right. And this is where you're going to be putting in the actual blade to do the cricoid procedure. This first cartilage here, this cartilage is called the cricoid cartilage, and it's the one that goes all the way around the trachea. All these other cartilages that are just below that, they actually have smooth muscle on the back. They don't surround the entire trachea. So what you see here on the sagittal view, and let me just move to this one, it's a little bit better. All right, here's that cricoid cartilage. Here is the cricothyroid membrane or ligament. All right, and so this is that little spot where you're actually going to be putting in the blade when you end up tubing somebody this way. So when somebody needs that, it's because everything up here above this glottis, right, has been disturbed. It could be because of a gunshot, too much trauma in the face, right? Something's going on where there is no way that you can actually get a tube in here. So then that's where you opt for this procedure. It is not something that is commonly done. Just keep that in mind, and very likely that you won't even do that in your entire career. So, but this is that cricoid cartilage that is the ring that goes all the way around the trachea. And the reason why is because this cartilage, what it does is it keeps that upper portion just below the glottis open. All right, very important for this not to get crushed. When somebody has trauma directly to that larynx, right, so if they get hit here or just slightly below and they crush this, that is when that person is going to be completely compromised in terms of their ability to breathe. Even a cric would probably not even save them. Then what you'll see here, these are called the arytenoid cartilages, and these actually are connected to your vocal cords, and what they do is they open and close, so they abduct and adduct and move the muscle that are then connected to the cords or to the vocal cords that then allow you to be able to speak. Then what you're seeing here, this gives you an idea of, so there'll be different things that you'll be learning when you get to the airway chapter, and they'll be talking about ways to evaluate what's going to be an easy airway, a difficult airway. Don't always assume it's going to be, it's going to be easy, right? Always expect to do your very best and always be ready, right? So you got to set yourself up for success. And how you're going to do that is by practicing a lot on the cadavers when you guys have the opportunity for that, and doing tons and tons and tons and tons of reps on these dummies that we're going to have, our little mannequins. Because what happens is you have to be good at when you're going to open that person's mouth. So when you look in the mouth of the actual mannequin, right, they've made them to look as close as possible to actual humans. And so this first thing that you're looking at is called a Malin-Patty score. And what you'll see is that it's graded 1 to 4. So 1 is the easiest, right? It's open, it's wide, nothing's in the way. A 4 is extremely difficult. So this is when you have a lot of edema in the back of the throat. The tongue is also swollen, right? So this would be a nice diagram of what can happen when somebody has an actual obstruction because of edema in the throat. And so what you see progressively as you're working your way through is that there's more and more swelling in that back area. So this thing that's called lemon just means look, evaluate, Malin-Patty, which are these classes, and then is there obstruction, and then what does the person's neck look like? So short, fatty, stubby necks are going to be a little bit more difficult because you're going to have a little bit more of a challenging procedure in being able to get that head back, because sometimes the adipose tissue doesn't allow for the head to drop back the way that you need to. So sometimes, and you guys will learn how to do this, is when you absolutely have to, in some cases, you're going to have to intubate from the front. All right, and it is possible. And you guys will get some reps at that, but it's not something that happens very often. Then when you look at this other grading, this is called the Cormack-Lehane classification, and now you're looking further down into that actual portion where you're going to put the tube. So this grade 1 here, right, there's still a little bit of edema here, but this is the actual epiglottis. And so what you're looking at here in this piece here, this is the blade. And so what you do is you push the blade down, and I'll show you guys the ligament in a little bit. And you want that epiglottis to get out of your way, because this is where you want the tube to go. You can still see a little bit of the vocal cords, and what you're looking at here is just that lateral portion of the opening of the glottis. Then as you move over to grade 2, you can see that now we've got a bit more edema. This region here is a little bit more inflamed, much more difficult to get a tube in here. Grade 3, even more challenging, right? You can barely see the epiglottis here. There's a lot of edema on that posterior portion anterior to the epiglottis, a lot of it just posterior to that, and then obviously on the sides. And then this one is virtually impossible, right? I mean, in order to get a tube, you'd have to like really squeeze through here. And sometimes it's going to be very, very difficult to do that. So in this case, with a grade 4, it's very possible that you would be having to make the choice to do a cricoid procedure. So when you put them together, again, it comes down to how easy is it to get that tube into the mouth and then down into that airway. And so your class 1 and grade 1 are going to be the easiest ones, and then as you move up, these are going to be the most challenging. So that's how you move from a easier airway to a more challenging airway. Then here's a diagram of what you'll ideally see when you're intubating somebody that doesn't have edema going on in their throat. So obviously here's their tongue, here's that portion of the epiglottis, and then just posterior to that there's going to be the ligament that you're going to want to put the blade. And then below that, obviously, you can see that this is the opening into the trachea, and these little ridges that you see, these are the cartilages. And when you're learning how to intubate, one thing that's going to be very helpful for you is for you to learn how to use a bougie. All right, a bougie is just this piece of very bendable plastic that is going to be your best friend in terms of helping guide that tube into the actual airway. All the actual tubes come with stylets that are, also bendy plastic, but they're not as long as the bougie. And with the bougie, you can actually bend it a little bit better to help make that entrance into the airway much easier instead of going in and making the mistake of intubating the esophagus. So that is why it's nice to learn how to use that. The esophagus is actually located back here. So this is posterior, this is going to be anterior. Then when you look at a real one, all right, here's where those vocal cords are adducted. So now they are closed. Your epiglottis is right here. And then this is when the cords are obviously opened and much, much easier to be able to get the tube in. And then here are your cartilages that you can see very easily. When you look at the, when you get your blade in there, and if you guys are going to be using the video scopes, which are awesome because you can see really well and you don't have to be as close to the person's mouth when you're doing this, this is that hyoepiglottic ligament. And so what you want to do is you want to place your blade exactly in the middle here. And when you pop your blade right here, what it does is that it takes this epiglottis and lifts it. It pushes it up and back. And it's like it's saying, welcome to the vocal cords, right? So what you'll see here, here's the blade. It's right on that hyoepiglottic ligament. And then here you can see where the tube has actually gone in very, very easily. So there are really good videos on YouTube, and that link that I've showed you guys were for how to intubate, or not, sorry, for how to intubate, but the airway videos on YouTube. There is one that I've listed that is excellent. It's a great tutorial by an anesthesiologist from the U of A, and she goes through and explains how to do that really, really well. But this right here, this is going to be your money. Man, you hit that right there in the middle and just pop it down. You don't even have to like hit a lot of pressure on it. And literally this epiglottis will like open up like it's saying, come on in, let's put that tube in and get this person breathing. So it's pretty awesome when that happens, and you'll see it'll be really obvious if you get when you guys are doing it in the cadaver lab. It actually makes you feel pretty cool, like you actually know what you're doing. So here's what you're looking for. So it's that ligament there, and then this is what you want it to look like once you pop that in and you can get the tube in. This is where you've not engaged that hyoepiglottic ligament. This is where you've now actually hit it off to the side, and now what's happened is now that epiglottis is sideways. It's going to be much more difficult to actually be able to get the tube in here, right? You don't want to have to fight for it. So this right here, this is part of that hyoepiglottic ligament, and this is where that error has been made. Here it's nice, right in the middle, it pops right up. Then a pediatric airway, why I wanted to show you this in terms of what happens is that in kids and peds, it is much more difficult to intubate. One, they're smaller, right? And they're going to be, actually their airways are going to be a lot more anterior and upright. And so what happens is the epiglottis is smaller, but it's also more curved like this. It's not going to be nice and floppy like what you would find with more of an adult. But you still have a hyoepiglottic ligament back there. And so that's why when you're using the blade, and this is why we recommend that you use the Miller blades for these, because they're more upright, they're more vertical, you're going to have a little bit more success. And again, it comes down to you doing your reps, practicing, and getting comfortable with just getting that blade and that procedure in. And the other thing you want to remember about when you learn to intubate is that this is a finesse procedure. This is not a let's use as much muscle and like force it down there and jam it in. Remember, you are working with a person's tissue here. This is all tissue that can be irritated when you're, basically going in there and maneuvering and manipulating the blade and the tube to try and get that in. And so keep that in mind, because remember that anytime you irritate tissue, there will be inflammation, right? And so inflammation is something then that's going to have to heal. And so this is why the better you get at your intubations, the more practice you get, even when you get past medic school and now you're out in the field, get the reps at your EMS location when you're working with your mannequins so that you can continue to get better and better at it, right? No one ever said, I don't need to practice airway anymore. Everybody has to practice airway. I don't care how long you've been in practice. So this is your epiglottis when you're looking at an infant. Here it's going to be more for a toddler, so obviously it gets a little bit bigger, but still a little bit upright. And now here you're looking at more of that adult airway, also what it is that you see down here. So you can see why with kids it's going to be a little bit more challenging. But again, your money is going to be right here where you put that blade and then pop that epiglottis out of the way, opens up like this, and then there it is, your little opening that you're aiming for. So just a little tip there for you guys when you're doing your airways. All right, so then let's talk about the trachea. So obviously this is anterior to the esophagus. So again, here's our diagram. Here is our cadaver. So when you go in, right, you'll put in your blade. So you're going to be coming in from behind here. You'll be behind the person's head. Then you're putting in your blade and you're placing that hyoepiglottic, the blade onto hyoepiglottic ligament, which is going to be right in the middle where the epiglottis is. It'll pop up the way we want it, and then you can come in and put in your tube. And so that's what you're looking for. All right, and again, it's really easy to get the tube in the back in the esophagus because of how vertical this portion is. You have to actually curve in to get to the trachea. And this is where the bougie comes in, because the bougie actually allows you on the end of it to actually bend it like a hockey stick and then have that point pointing in this way so that you can then pop it in. You'll feel the cartilaginous rings, and all you got to do is slide the tube right over it. It's pretty cool. All right, then your carina, don't forget, this is where the primary bronchi branch off into left and right, and then where the actual tubing, the bronchi, enter into the lungs, and also where the pulmonary arteries and pulmonary veins are going to be located in the lung as they're coming, from the heart and then out back to the heart, is this region that's called the hilum. All right, so this is that point of entry, and it's going to be in the medial aspect of the actual lungs. Then your primary medstem bronchi, remember, divide into the secondary, or what they call lobar bronchi, and then they will divide into tertiary, what we call segmental bronchi. And the segments are important because there's 10 of them, and so when you're learning how to do your lung sounds, right, you're going to be doing your lung sounds left, on the right, then on the left, on the right, and on the left. So you always want to do both sides simultaneously. If you only do the anterior portion at the apex, which is going to be up here on the chest, you're going to miss everything down here, right? And plus, when you're up here on the chest, you're actually hearing more bronchial, tracheal type sounds. You're not going to get deep into the actual alveoli to actually be able to hear if there is any fluid or any wet lungs towards the bottom. These are the segments. So this is why what's important is for you to learn, and it's best to actually get the lung sounds on the person's back. And so you'll do your left, your right, and your left, right, and left, right, and left. So you're getting all the regions on the lungs, all right? So you want to do 3 on one side, 3 on the other. And then these are the segments in terms of how they divide from that tertiary bronchi, and then these little guys will get smaller and smaller and then go into the bronchioles. The bronchioles break up into what are called terminal and respiratory bronchioles, and then they form into a little duct that then leads into the alveoli. And so as we get into the microscopic anatomy, back here we still had little tiny bronchi with cartilage. Now we're getting into this microscopic anatomy. Now this tubing is going to be a little bit more muscular. You're going to have smooth muscles surrounding it, and the inner lining is much, much smaller in diameter, right? So this tube here is very tight. But the reason why air can distribute so easily and go in easily, and there's very minimal resistance when you get down deep into the lungs, is because the surface area for the alveoli is huge, all right? You have about approximately 250 square feet of surface area with all these alveoli. So think about spreading it out over into a room that is about 10 by 15, all right? That's how much surface area you have. So that is why the resistance, as the air is coming in, it's real easy to get the air into these alveoli. So this is where it comes through. So we want these bronchioles to be open. You don't want there to be a bunch of goo and secretions in here. And the other thing that I want you to note on the alveoli is that you have these little fibers and these little yellow, they look like little rubber bands around them. These are elastic fibers that are very, very important, because what they do is when you inhale air, your alveoli fill with air, right? And they expand, they stretch like a little balloon. And then what happens, the elasticity of these fibers around the alveoli function like the elasticity of a balloon. When you let go, you open up the top, right? And you let the air out, it's able to recoil without you having to force the air out of the balloon. And so that is what allows us to breathe out when we're at rest, to passively exhale, because then these little elastic fibers allow for those alveoli to recoil and go back to their original resting length. And so that's why these matter so much. With emphysema, what happens is that the alveoli themselves start to stretch out and deform, and they hypertrophy and stay stretched, and then end up causing that these elastic fibers become brittle. And so then what happens is the air comes in, but it stays trapped. And it's very difficult for the person to exhale because they don't have that nice elastic fiber around the alveoli to then be able to go and push the air out. So this is why when people have emphysema, it takes a lot longer for them to be able to exhale. So alveoli, remember, they are little teeny tiny sacs. We have about 300 million in each lung. Obviously huge surface area for these. And then we have this alveolo-capillary membrane, and this is where the gas exchange takes place. And so when you look at it, what happens is the alveoli and the capillary walls are going to fuse together. So when you look at the image, this is, a half of your alveoli, and then you're going to have all these capillaries all around them. And then you also have cells along the alveoli that are going to be macrophages to help in terms of immunity, but then you also have other cells that help produce this stuff called surfactant. And what surfactant does is that it keeps these alveoli from the membranes sticking together, because then you'd be like you'd have a wet balloon on the inside and it doesn't want to inflate. So that would actually increase resistance. It would make it more difficult. So you never want to have a whole lot of fluid buildup in here or something that is causing these alveoli to stick. And so when you get inflammation and you get mucus secretions and they end up in the alveoli, obviously that makes it more difficult to breathe. What it also does is it ends up affecting this, which is, this is the alveoli membrane, this is the capillary membrane right here. So when you inhale, you actually cause that alveoli to expand with air, so it stretches and it brings closer these two membranes. And so now what you've done is you actually have a really nice, tight membrane that is permeable to those gases. So it makes it very easy for the oxygen to come from the alveoli into that capillary, load onto the red blood cell, and for the carbon dioxide that is in the blood to unload and then enter into the alveoli so you can exhale it. So this is why it's so important to make sure that our capillary network and our alveoli are healthy and not full of debris and gunk. When you have pulmonary edema, when you have fluid, what starts to build up is fluid in here in between the space, and then you also end up getting fluid in the alveoli. And so what that does is it actually makes it much more difficult for this diffusion process of the gases and the exchange to happen, because now you've got fluid in the way. And I don't know about you, but I can't breathe in water. So it makes it much more difficult, and you have increased resistance, and then you end up having stuff in the way, and it makes it very difficult to be able to breathe. Then as you see this kind of like, zoomed in, blown up view of what you're looking at here, this is the pulmonary artery coming in. So it's going to deliver that, deoxygenated blood to the alveoli. This at the capillary bed is where you're going to have the exchange happen, and then the pulmonary veins will then take it and return it back to the heart. And then this is kind of what it looks like when you look at it microscopically. So healthy lungs are actually going to look pink, all right? So if you get the chance when you're in the cadaver lab for them to open the thoracic cavity, you can actually see what the lungs look like. And if the person was a smoker or they were exposed to a lot of pulmonary toxins, you will see that there is a difference in terms of what the lung tissue actually looks like. All right, then our lungs, the right lung has 3 lobes, upper, middle, and lower, and then the left lung has 2 lobes. And then the left lung also has this thing that is called the cardiac impression, which is the portion where the heart kind of sits in and tilting more towards that left side. So this piece right here, this is where the cardiac impression is located, and then this is your upper lobe for the left and lower lobe here, and then here is your upper, middle, and lower lobe for the right lung. And then the region, again, where the heart is located and where you have, your aorta and your vena cava coming through, this is all that mediastinum region. Then you have your diaphragm, and then surrounding the lungs, you have 2 membranes. Right on the surface of the lung itself, you have what's called the visceral pleura. So very similar to the visceral pericardium, which is that epicardium layer that's on the heart. And then you're going to have a little space, and then you have an outer membrane that is called the parietal pleura. And why that matters is that this space is critically important for us to be able to ventilate. What that means is for air to be able to come in through the trachea, enter into those bronchi, and then diffuse into our actual alveoli. And so this membrane right here has to be intact. You don't want any of this getting torn, having air go in it, because if it does, then air from that lung is going to leak out into this, which is your thoracic cavity, and then the lung itself is actually going to start to collapse because the pressure of the air out here is going to squish down onto the lung, and it can happen on both sides. Or if you have fluid, right, you have a lot of fluid building up in here from a pleural effusion or something's going on in the lung, where you now have a lot of inflammation and now fluid is actually seeping out, and it's also going into this space, it's going to make it very, very difficult for a person to breathe. So what we have with those membranes, right, is what we have are called pressures. So in the lung, right, there's going to be a pressure that comes in, right? So when you inhale air, you're going to have diffusion of air happening. You have air moving from higher pressure to where it's in lower pressure here in the lungs. And so the air will flow from high to low. When you exhale, you want the air inside the lungs to create a positive pressure, and then it's going to move from high here to where it's lower out here. And that is how you can move the air in and out. But what happens is, again, you have these membranes, right? So here's the visceral pleura right on the actual membrane of the lung. And then the outer membrane surrounding it is the parietal pleura. There is a little teeny tiny space that's called the pleural space or pleural cavity. This pressure in here always has to be less than the pressure in the lung. Because if it's not, if this pressure gets greater than what's in here or coming in from out here, you will not be able to fill your lung and expand it, because what it's doing when it fills is that it's growing and then it's going to move this way, right? And so this area has to have less pressure than in here. Otherwise, you can't expand the lungs because you would have too much pressure out here pushing down this way. So that is why this intrapleural pressure, or the pressure in the pleural space or cavity, is always negative. And what that means is that it's negative, meaning less than the pressure that ends up in the lung and the pressure that is out here outside of the lung. So that's a really, really important thing for you to remember. So remember that if the intrapleural pressure is high, meaning it's greater than the intra-alveolar or intrapulmonary pressure, then you're not going to be able to ventilate. Then your pulmonary circuit, remember, is from the right side of the heart. It's going to pump the blood to the lungs, so that's where you're going to get your deoxygenated blood. And then at the level of the alveoli and the capillaries, that is where you have the gas exchange take place. And then the pulmonary veins will return the oxygenated blood back to the left side of the heart. Your systemic circuit, that one is going to be your circuit from the left side of the heart that then pumps the blood out into the tissues. But the lungs themselves also are tissue. So what happens is the alveoli actually receive their oxygenation from the blood that is coming in through those pulmonary arteries. Remember that even though the blood has a lower oxygen concentration than the arterial blood that is rich in oxygen in the systemic circuit, we still have enough in there to be able to oxygenate the tissue, the actual cells of the alveoli. And then the bronchial arteries actually come off the systemic circuit, and then those will feed in from the actual remaining of that lung tissue that is not alveoli. So the bronchioles, the bronchi, that tissue is going to receive its blood supply and oxygen from these bronchial arteries, and then the bronchial veins will take the deoxygenated blood back away, boom, and then they put it into the inferior vena cava, and then off it goes. So it's pretty cool. All right, so the word pulmonary ventilation, remember that means the movement of air, so inhaling, exhaling. And so inspiration means to inhale, expiration means to exhale. And these are the two phases of ventilation. When you breathe in, what you're doing, and we're going to assume right now that we're all in San Diego at sea level. Phoenix is actually at a slight elevation. But when you're in San Diego at sea level, what we have is atmospheric pressure. And so what we call this is 1 ATM. ATM stands for atmospheric pressure. And 1 atmosphere is equal to 760 millimeters of mercury at sea level. The respiratory pressures, which refer to what's going on in the lungs, remember that in order for air to flow, we need a pressure gradient, which means it has to go from high to low. So inside the lung, we're going to have the diaphragm. When you inhale, it contracts and goes down, and what it does is it creates more space in the thoracic cavity. What that means is now you have more volume, which means you have less pressure. And so what you're doing with your diaphragm is you are creating negative pressure inside that thoracic cavity. So air is going to flow from the outside, from the atmosphere, in to where it's lower in the lung, and then air flows in. Now we want to exhale. So now what happens is we have our diaphragm create positive pressure when it's going back to its state where it's just going to go back to its original resting length, which means it's going to now relax. And as that happens, it causes the lungs to deflate because now it's pushing up on the actual lungs, and then that creates the negative pressure to force the air out. And so that is what we're able to do in terms of moving our air because of the pressure gradients that are created by what the diaphragm is helping us do inside that thoracic cavity. So again, you have your diaphragm here. Air is going to come in through the trachea, fill in into the bronchi, make its way down to the alveoli. And so when this diaphragm contracts, it pushes down, right, creating a lot more space in here, which means we now have more volume, so you have less pressure. So now air flows in, and then when you want to exhale, now you actually, the diaphragm itself is going to go up, pushes the air out, right, forces those lungs to decrease in terms of the amount of volume that there is because you've now created pressure as you're pushing up, and the air is now going to flow from inside the lung on out. Then the intrapulmonary or intraalveolar pressure, this is just air pressure in the alveoli, all right? And obviously it fluctuates with breathing, right? It increases when you inhale and the air is going to flow in, right? Now we're going to create more volume. And now when we want to exhale, now we're going to create increased pressure to now force the air on out. So inhaling is going to create that negative pressure, comes in, we have more volume, and now we exhale, create positive pressure on the inside relative to the outside, and now we exhale. Intrapleural, again, remember this is the pressure in that pleural cavity, which is the membrane between the visceral and parietal pleura, that space, and it always, always, always has to be a negative pressure, because if you don't have negative pressure in there, which means it's a lower number than what is in the atmosphere and what is created in the thoracic cavity when we are actually exhaling, otherwise we can't move air in and out. So that intrapleural pressure is always negative. All right, so again, just to show you the picture, this is that intrapleural pressure between the two membranes. Then transpulmonary pressure, this is just the difference between the intrapulmonary and the pleural. And again, this should always be a positive number, because if it's not a positive number, that means that the difference between these two would be a negative number, and that would mean that the intrapleural pressure would be greater. So that is why that can't be negative. So that's why it's important to always have more pressure that's going into the lung, leaving the lung, relative to what is in that pleural space. All right, so this is your negative pressure area. Then the word for a lung collapse is called atelectasis. All right, so this is when your lung collapses. Basically what happens is the bronchioles can become plugged, and so that will cause those alveoli to deflate. They'll basically get close together, and then when you have a whole bunch of those obviously happening, it's going to cause that lung to actually shrink down in size. It's almost like a deflated balloon, and you actually do see that on an x-ray. When that atelectasis happens, you can end up with what's called a pneumothorax, which means that now that there's some kind of wound that has actually caused a puncture in that pleural membrane and through that visceral pleural membrane, and now there's going to be air from inside those alveoli leaking out into the pleural cavity and out into the thoracic cavity. So this is when you have air that is in the thoracic cavity. So the word pneum, P-N-E-U-M, this is referring to that portion where it's referring to the lungs, and now it's telling you where it is. It's in the thorax. So this is what you would see. So these are intact lungs where everything is normal. And now what happens over here on the right, the little red area here, that is showing you where the membrane of that right lung has now collapsed, and it's not filled up in here. The left lung over here, this is a full lung. On this side, this little edge that you're seeing, that is a collapsed lung. And so now we have a pneumo on the right lung. So the way that you will alleviate this, and you'll see this in a few slides further down, is you actually do what's called a needle decompression. So you're actually sticking a 10 gauge or 14 gauge needle, if you don't have a 10, into the spaces. So it's going to be the space up here between the second and third rib to actually start relieving some of that air pressure that's in there, and then helping hopefully allow that lung to gradually start reinflating. But it's not going to be something that you can do completely in the field. This person is going to have to be transported to the ER, because they're going to have to put in a chest tube, which can be extremely painful, but it's better than having a collapsed lung. Then when you have blood in the space, so that can happen right from some kind of puncture injuries, some kind of stabbing, gunshot, right, a contusion, a really severe trauma, then you end up with what's called a hemothorax. So now you've got blood in that thoracic cavity, and then you can end up with a hemopneumo, where you have blood and air, and that can cause a lot of problems as well. And then the tension pneumothorax, this occurs when you now have progressive buildup of air on one side of the lungs, and now it's actually causing that air, the pressure that it's exerting on the organs in the mediastinum, which remember is where your heart is located, it starts pushing it to the opposite side. And that's a problem, because it's going to start causing problems in terms of blood flow return back to the heart and the ability for that person to breathe. So this is what you would see if you saw what's called a right hemopneumo. So this is a hemothorax, where you actually have all this fluid that is building up. This piece right here that you see, this is the heart, and all of this here is actual fluid. So this person's having a very, very difficult time breathing. When you look at this picture, this is where we have a tension pneumothorax. So what you're looking at here, these are the vertebrae, and then anterior to that obviously would be where the esophagus is, and then anterior to that is going to be the trachea. So you can't see very well in here where the trachea is actually located, but you can see that the heart is actually shifted to the left. All of this right here that you're seeing, all this dark stuff, this is all air that is actually filled in into this cavity, and now it's pushed the heart over to the right. And then remember that is what's running through here is going to be your inferior vena cava, up here your superior vena cava, and then you also have the aorta descending behind the heart. So you're actually affecting the ability for blood to flow back properly, and you've now shifted the organ the other way, and now you have pressure as well on the heart. So this person is in a lot of trouble. This is a real critical injury. And so one of the things that you learned when you were going through EMT was when you're doing your trauma assessment, you're looking for tracheal deviation. Well, tracheal deviation is going to be a later sign that a pneumo is actually happening. If your patient is conscious, they're going to be telling you, I can't breathe. I'm having a really hard time breathing. And you can just assume that what is taking place is that they probably have air leaking into that thoracic cavity, and you're going to have to take action by starting to do that needle decompression and releasing some of that air that is occurring. So again, what happens with that, remember here's your trachea. When you start having air building up, because this now has been injured, now you have air going into the cavity, it's going to start shifting things the opposite way. Or if it happened on this side, now you're shifting things to the other side. Then in terms of where you're going to be doing this needle decompression, one thing that I need to again show you guys is we need to look at the sternum. So remember that the sternum is that central bone down the midline of the chest. And up here at the top, this is your manubrium, and then you have the body of the sternum, and then here you have the xiphoid process. So if you were to look at the sternum here, this little part up here, this is where the actual clavicle articulates to the manubrium. And then just below that, so midline of the manubrium, just lateral, this is where you have the first rib. Then if you take your finger and you palpate up here and find that sternal notch, and you drop it straight down, you're going to feel this little bump right here. Where that little bump drops off, when you go lateral to that, that is exactly where the second rib is located. And then just below that, that little drop off, this is where that second intercostal space is. So this is going to be where you're going to insert to start doing the needle decompression. What you want to do is right here, here's your clavicle, right? And so the area that we're going to be looking at is going to be right in this space here. You need to find that mid-clavicular line. So that means the middle of that clavicle, because you don't want to be here, right, on either side, because otherwise you're too close to the heart and you could actually do more damage. You want to be away from those vital organs, from the heart, from the vena cava, from the thymus, from the aorta, right? The aorta is going to be passing back through the back. So what you're going to do is you find that mid-clavicular line, which is usually along here. If the person is fairly lean and the nipple line is fairly through the middle, that is approximately where that is. And so this is where you would start. You would put your needle in here, and they teach in class to start with one, but one may not be enough, so maybe 2, 3 at a time, popping them in. And what you wanted to do is you wanted to relieve the air that has actually built up in here. What's also important is that you go from the top to the bottom. So what you're looking at here is where that mid-clavicular line is, right? And then where the manubrium is going to be located and where you're going to be finding those landmarks. So up here is where that person's sternal notch is. Here is their manubrium. Then it drops down, and then where you're going to have your intercostal space that you want to go in and put the needle is going to be right here in that second intercostal space. So you can see out here on this side where that is located. And so what you're doing is you're going in perpendicular to insert that 10-gauge needle into the space. And so what you'll do is you're actually popping in, so you're popping through that. And I want you guys to think of a rack of ribs. So think about how thick that rib meat is. And we're talking when it's raw, all right, because this is raw. And so you're going to put your needle in, right? You're going through the skin, through muscle, and then through the actual intercostal space. So you've got skin, adipose tissue, pectoral muscle, and then popping through the intercostal space. And so in some cases, you're going to have to go through a little bit more. But as soon as you feel that little pop, right, and you'll feel this and you'll practice this in class, you're done. You're through. Now you thread this white stuff, which is your catheter, into the space. You don't take your needle and go all the way in and bury the hub in the person's chest. If you do that, you're going to do some damage. So it's not that you're taking the needle and going in all the way, all right? You are simply using the needle as your tool to puncture the chest, get through that intercostal space of the tissue, and then thread the catheter through. And then you put the catheter all the way through, and then the hub of the needle will be located in that spot. And so that's what you're doing when you're doing this needle decompression. You also want to be above the neurovascular bundle. So what you see here and how it's shown on the actual slide is you have artery. So you got thoracic artery, thoracic vein, and thoracic nerve passing through that portion. And so you don't want to go from the bottom up ever. You don't go from the bottom up this way. You're going from the top down when you're going in and doing that needle decompression. And so again, this is where it's going to be important that you practice. First, it's real easy to just do on a skeleton, put a piece of tape on there, and then just practice doing your little decompressions with that. And then you can also practice on the dummies. Obviously, you're not going to practice this on each other because that would not be a good idea unless you're having a problem. And then when you get to the cadaver lab, you'll get a lot of reps at this. The other spot, and actually the preferred spot to do this, is going to be in the region that is within the axillary area. So what you're looking at is this mid-axillary line. So here's your axilla, all right? And you're going to have this like little triangle that forms with your mammary line. So when you look at this part over here on this side, here is the xiphoid process. This is where the rib cartilage is running through. So if you find that xiphoid process, you just run the rib cartilage up and you get to here and then draw an exact parallel line to where that xiphoid is. This is that line, which is that fifth intercostal space just below the nipple. Now granted, if you have a patient that has breasts, they're not going to be very easy to find, like this one's a male, right? You can easily find that intercostal space. The person is lean. This is like the perfect patient, which is never. So right here, you need to find that portion and then you just go straight across. So you're going to find that line that we call the mammary line right below, go straight across, and then you look at that anterior portion here of the axilla, and now it's going to run straight down, right? So this is going to be this region where you have your mid-axillary here, and then where you're going to run and you're going to do your needle decompression is going to be right in this space between the fourth and the fifth, all right? So right here, you're looking at between the fourth and the fifth intercostal space. You can also do between the third and the fourth. And so these spaces up here, as you can see, are going to be wider. There also tends to be less fat and tissue in that area, so that is why this is a preferred spot. Once the person gets into the ER, that is very likely where it is that they're going to go ahead and insert the chest tube when they have to go in. And so what you're doing again is you're going above the neurovascular bundle because you don't want to damage that, and you want to put in the needle so you can start decompressing the air. And once again, you're using the needle as a tool to get through the tissue, the fat, the muscle, and then the intercostal muscle. Once you feel that pop through, then you thread through your catheter and then you're in. So that's your needle decompression. Then as far as ventilation, right? So when you're breathing, you're going to be ventilating, you're going to be inhaling, and that's going to be bringing the air in to the lungs. And the thing that's going to stimulate the diaphragm again is the phrenic nerve. And why we care about that is remember that this phrenic nerve comes off the roots of the third, fourth, and fifth cervical nerves. And so this is why when somebody has a cervical injury, right, there is concern about something happening in terms of the phrenic nerve. And so if you suspect that there is any kind of cervical issue going on and your patient, if they're conscious, are telling you, I'm having a really hard time breathing and I can't take a deep breath, you better start thinking that this person could potentially have a cervical, something wrong with the spinal cord or that there's an actual inflammation taking place there. So this is a really, really important nerve, right? And it's going to help you obviously with those external intercostals also to contract. And then when you're exhaling, again, you're going to create positive pressure inside that thoracic cavity, and it's going to allow for that air to flow out. And then what happens for that is the phrenic nerve is now inhibited, so it stops the stimulation of the diaphragm. And then when it relaxes, it allows for that to exhale. And then your internal intercostals are the muscles that then help you when you want to force more air out. It actually compresses the rib cage. So when we look at how we breathe in and breathe out, when you're inhaling, right, you're going to increase the space, the volume of where the lungs are located. And we have this muscle here, the sternocleidomastoid, which is also the muscle that allows you to move your head left to right. and this muscle here called the pectoralis minor and your external intercostals that are all going to work together to expand the rib cage. So what is happening here is that you're actually causing this space to get bigger, and that allows you to fill with air inside the lungs. And then when you're going to exhale, now you're going to compress, right, the rib cage. And so now your internal intercostals kind of help bring those bones closer together. You're going to relax the sternocleidomastoid, you relax the pectoralis minor, and most importantly, that diaphragm relaxes and then allows for that air to flow through, up, and out of the lungs. Then how much resistance is encountered with the air as it's flowing in? The biggest resistance is always going to be at the level of the entry. So this is where you're coming in through the trachea. So this is where you're going to encounter the most resistance, and then as you're getting into the bronchi, and then once we get down into the smaller and smaller segments, and those bronchi get smaller and smaller, and we get down to the bronchioles, remember the surface area for where the air can travel is huge. And so what it does, it basically decreases the resistance almost to zero. And so once we get into that zone, which is where the alveoli are located, that is called the respiratory zone, the region that has all the tubing and the bronchioles, that is called the conducting zone, because the air conducts through there. And so this respiratory zone is going to basically give no resistance as that air enters and is able to easily get distributed into those alveoli, right? And of course, I'm talking about when somebody is obviously very healthy and able to, fill their lungs with air. Your total lung volume, all right, is how much air, 100%, can you hold in your lungs. A lot of this is going to be dependent on your size and also how healthy you are and how aerobically fit you are. And so if you're somebody that is really healthy, you do tons of cardio, right? You've never smoked, you take care of yourself, obviously your lung capacity is going to be really good. Your volume that you're going to be able to bring in there is going to be excellent. So a spirometer is one of these little dial looking things that we blow into that allows us to be able to measure our vital capacity. So I'm going to go through these next tables, and what we're going to do is you're going to look at what the definitions of the volumes are, and then what the volumes do is you add them up or subtract to then give you capacities. So the volume is just the air that fits, and then the capacity is what allows you to do something with that air, right? And so your tidal volume, I want to make sure that you guys always remember this, on average is about 500 milliliters of air. So when you're looking at a little water bottle, it's about that much air that you can move in and out of your lungs in a normal breathing. So when you're inhaling or exhaling, that's how much air you're moving through. If you were to inhale after you've just taken a normal little inhale, now you say inhale as much as you possibly can. Well, now you can hold a whole lot more of air because now you have what's called inspiratory reserve volume. So it's the amount of air that comes in after you've done a normal tidal volume inhalation. Then when you go to exhale, you exhale out and you have the volume that you would exhale normally. And then if you exhale beyond your normal exhale tidal, now you have what's called expiratory reserve volume. So if I said, now that you've exhaled normally, keep going. So you're going to exhale as much air as you possibly can until you feel like, oh my God, I can't breathe. Now you've done what's called, you've exhaled that expiratory reserve volume. But there's always a little bit left behind, and that is the residual volume. So when you look at what these volumes are, we can then put them together in capacities. So your total lung capacity is all your volumes added together. Your tidal volume, your inspiratory reserve volume, your expiratory reserve volume, and the residual volume, which is the air left in the lungs after a maximum exhale. You always have air left behind. You can't get rid of 100% of your air. Then your vital capacity, which is what you can measure with these little spirometers, is your tidal volume plus your inspiratory reserve volume, so how much you inhale after a normal inhalation, and your expiratory reserve volume, which is how much you exhale after a normal exhalation. Inspiratory capacity, this is how much total air you can inhale, right? And then your expiratory capacity obviously would be how much air can you exhale. And then this functional residual capacity, this is what we're looking at when you do the amount of air left in the lungs after your normal tidal volume expiration, which is just our normal Joe exhale. So when you look at it in the chart, this is where I think it's a little bit easier. Here's your tidal volume, right? So you inhale, exhale, exhale. And then I say, okay, now I want you to inhale as much as you possibly can after you've done your normal inhale. So that would be this right here, right? So you can bring in a lot more air. Now you exhale. So now we exhale. And then I say, okay, now I want you to exhale and keep exhaling until you can't exhale anymore. And now you have this right here, which is your expiratory reserve volume. So your vital capacity is this, right? How much air you can inhale total and how much air you can exhale total. That is going to give us an idea of, hey, how healthy are your lungs? This residual volume, remember, this is going to be the volume of air that is left behind after you've exhaled maximally. So you've blown out all the air you possibly can. And then your total lung capacity is your total, right? We add them all together. So how much air you can move through those lungs is going to be, again, dependent on how healthy you are, right? How aerobically fit you are, because then that ties into how aerobically fit, right? And how strong your diaphragm and your intercostal muscles are. And then obviously how healthy the lungs are. So that's why we care about these respiratory volumes and these capacities. Then non-respiratory air movements, these are your coughing, your sneezing, your crying, laughing, hiccups, those kinds of things, right? Because you're not really doing much with this. Then respiratory sounds, you're going to be learning in lab, and you probably have already done a little bit of this when you're going through your patient assessment, are going to be, you have your bronchial sounds and your vesicular sounds. Bronchial, these are going to be louder, and they're going to sound like more air moving through a tube. These are going to be along more the surface area where you have bronchi, right? So like if you're close to the trachea or just lateral to that, that's going to be a bronchial sound. Vesicular sounds, these are going to be softer sounds that sound a little bit like a breeze, but inside the lungs, right? They're not going to be as loud. And the best place to listen to these vesicular breathing sounds are actually that spot where you would do that needle decompression within that 4th and 5th intercostal space along that mid-axillary line. And so that's a real nice area to actually listen for these vesicular breathing sounds. All right, so external respiration, this is going to involve what happens with the gas exchanges that are taking place, and then what happens at the lung level with the blood, and then again at the tissue level with the blood. So this is your diffusion of gas, right? So we're going to have gas exchange taking place. So again, when we look at this, remember that external respiration is your alveoli. So that's where oxygen came in. It's going to load into the blood. Carbon dioxide from the blood is the deoxygenated blood, and that's going to load from the blood or unload from the blood into the alveoli. Then it gets transported, right? So the oxygen will get transported to the tissues. At the tissue level, you're going to have your oxygen unload into the tissue, and then the carbon dioxide is going to move from the tissue and load into the blood. So factors that affect gas exchange have to do with these things called gas laws. And so there was this dude named Dalton that decided to do some math with gas, and he said if we add the gases, so each gas is going to contribute to the whole. So these are the partial pressures and the solubility of your gases, right? So your partial pressure of your gas is how much gas do we have in the air at that time, right? So there's multiple gases that we have. So in our atmosphere, we have nitrogen, oxygen, carbon dioxide, right? We have water vapor. Sometimes we have bad gases like carbon monoxide, but they're all contributing to the air that we breathe. So just like all of you sitting in a room, right? If each of you farted, you each would contribute to the stench that was in the room because you each had a partial pressure based on how much fart you released into the air. And of course, that's going to vary depending on what obviously you ate and what it is that you consider to be a big fart, little fart. All right, so that's a stupid way to remember it, but it's easy. So each partial pressure adds to the total pressure of what's in the air. What also happens is that each gas is going to have a solubility in terms of what its ability is to dissolve in the actual total pressure of what you have in the gas. So here's our gases. So in our atmosphere at sea level, remember we're all in San Diego, most of what we're breathing is nitrogen, then oxygen on average 21%. We have some carbon dioxide and our water vapor. That adds up to 100%. When you look at the actual mercury, right, the pressure itself, here we have 596 from nitrogen, approximately 160 from oxygen, 0.3 from carbon dioxide, and about 3.7 from our water vapor. And then in our alveoli, these pressures actually are going to decrease a little bit because remember, there's going to be a loss based on what stays stuck in that tubing as we work our way down. So we're going to lose some pressure, some volume as well as it moves from the outside air down into where the alveoli are. So when you look at what do we have available, right? So you guys all know that when you're at altitude, the air, right? Everybody says the air is thinner. And what that means is that the partial pressure of oxygen at altitude is actually less than what it is at sea level. So what you're looking at here on this image is that at altitude, the concentration of how much oxygen we have is less than what we have at the actual sea level. But the total contribution of oxygen at altitude based on the total air that we have is still 21%. All right? Nitrogen is still going to be a higher contributor than what we have at with oxygen. So that is basically how they do it. So at sea level, remember that on average we're at 760 millimeters of mercury. When you go up to altitude, right, the higher you go, the thinner the air is going to be. So for example, if you go to Flagstaff, so an average Flagstaff is about 7,000 feet of elevation. So if you were to divide that by, by 3, right? On average, that's going to give you your meters, and because 1 meter is on average 3 feet, and so that tells you approximately how tall that is. So anyway, so that's what we're looking at. So here's your like 10,000 feet, right? Here your pressure is equalized, right? Flagstaff probably going to be about here. And so that is why the air is going to be a little bit thinner when you go to altitude. If you go way up, right, way up, 30, 35,000, 40,000 feet, obviously you can breathe outside because there's very little oxygen to breathe out there. But our cabin pressure is at 10,000 feet on average. So that's why I want to include this, because it just gives you an idea of what it is that happens in terms of what's going on with your partial pressures of oxygen. So when you go to Flag, right, or you go to Denver, or you go to places that are at altitude, what you're going to notice is that your heart rate's going to increase. One, because you have less oxygen available to be transported through that blood, what would normally be down at sea level. But your body will, over time, if you stay there, become more efficient, because your body will actually respond by making more red blood cells. And also, it's going to challenge you more cardiovascularly, so your cardiovascular fitness actually will increase a little bit from just being up there. So, but that's what happens in terms of the gases. And then when you look at solubility, this is where Henry came in, so Dr. Henry. So here's your normal conditions, right? So you're going to have gases that at certain pressures, right, when there's no pressure exerted in the gas, you're going to have some gas that is not very soluble in fluid, and then other gases that are. But now you increase pressure on that gas, and you can actually force gases that aren't normally soluble in fluid to be more soluble, because now you've exerted pressure. So if you think about this in terms of diving, right, these scuba divers, so nitrogen is not soluble barely at all in fluid. Oxygen is very, very little that is soluble, but carbon dioxide is very easily soluble. And so what happens is when you add pressure to it, you actually force more of that air, right, those gases that are not soluble at normal atmosphere, to be increased with the pressure that is exerted by the actual depth of what you're doing when you're diving. And then it actually forces some of those gases to actually go into the actual blood. And so when you're going back up, right, we're going from depth to surface, you have to be very careful about how quickly you do that, because you don't want that nitrogen to end up in the tissue and then cause problems in terms of giving you what we call the bends. And when you go through the environmental emergency chapter, that's where you will learn a little bit more about what happens with individuals who are diving and they come up too quickly. So I don't know if any of you guys dive, but that is one of the things that would come up with that. All right, so when we breathe, all right, remember this is all about diffusion, so moving from high to low. So the gas will move from a higher concentration to where it's in lower concentration. So up here we are at the alveoli level. So we're going to breathe in our air, right? So here comes our air. And as it works its way through from the atmosphere into the alveoli, remember that you're going to lose some of that pressure because not 100% of the air ends up in the alveoli. So the partial pressure of oxygen up here in the air, 159 and 160, right? When it gets down to our alveoli, it's going to drop down. And then now we're going to have that oxygen that's going to diffuse into the actual blood. As it gets transported through the blood, gets back to the heart, and now is going to get pumped out into the systemic circulation. You will note that when it gets into the systemic circulation, that even then you're going to end up losing a little bit of that partial pressure. And that's okay. It's not a big deal. So once it gets transported down into the tissue, obviously the oxygen here is going to be in a higher concentration. It's going to be in much lower concentration when it gets into with what's in the remaining tissue. So we're going to move from high to low. Then carbon dioxide is going to be at a higher concentration because it was metabolized, right? We had glucose get metabolized. We produce carbon dioxide and water, and now we're going to have more carbon dioxide out here than we do in here, so the carbon dioxide will diffuse from the tissue into the capillary. And then it'll get transported from the venous blood back into the heart. And then from the heart, it gets pumped through the pulmonary circuit back into the alveoli. And then at the alveoli, it's going to diffuse from the blood into the alveoli, and then it goes on out. And so we always have this exchange of the gases. So again, remember that external respiration happens at the capillary level, so the blood and the alveoli, and then the tissue level, internal respiration in the tissues, happens from the blood to the tissues, and then from the tissues back into the actual blood. So our exchange of gases is going to happen through that membrane that's formed between the respiratory membrane, which is the alveoli, and the capillary membrane. And again, what happens has to do with the partial pressure gradients, high to low, and also the gas solubilities, which are very important. The other thing that really matters is this thing that's called ventilation perfusion coupling, which basically means you have to have good air coming in, good blood flow going to those alveoli, right? A good exchange of the gases, and then good ventilation, which means good exhale out to get rid of that gas that ends up in the alveoli, so we get rid of the carbon dioxide. And we also want there to be good loading of the oxygen into the blood because there's a good blood supply with good red blood cells that have now reached that alveoli, and then we can transport to the tissues. So this ventilation perfusion coupling, you want to think of it as a really awesome, perfect marriage relationship. So here's our membrane. So again, this is where we're going to have the gas exchange. So you need to have good blood flow with a good percentage of your red blood cells coming through, and you have to have good alveoli, healthy alveoli, good amount of air, right concentration of the gas of oxygen to then load happily into that capillary, and then for the carbon dioxide to unload from the capillary into the alveoli. So you want all of this to be healthy. And so where you want matching ventilation perfusion, it means good blood flow, so good perfusion to the alveoli, and ventilation, good airflow into the alveoli, so we can have that good gas exchange. So on average, your pulmonary arterial blood, remember that arterial blood coming from the heart in the pulmonary circuit is going to be your low concentration oxygen, and then the blood that is in there is also going to have a higher concentration of carbon dioxide. So in the alveoli, remember that we have, when we inhale, a higher concentration of oxygen relative to what is going to be in the blood. So we can have that loading of the oxygen from the alveoli moving into the capillary. And that happens very, very quickly. So it doesn't take very long. All right. So what is taking place is you have your loading of the oxygen based on your partial pressure, right, into that capillary. So here, obviously, the partial pressure is lower on the venous side, and then as the oxygen loads, it's going to saturate or partially saturate the hemoglobin, and now we're going to have a much greater concentration of oxygen in the alveoli, from the alveoli into the actual red blood cell. So that is why you end up seeing this where it's now more concentrated. And it doesn't take long, look, almost less than a fourth of a second, a quarter of a second to load. So the blood with your carbon dioxide, remember that blood as it's coming into the alveoli through those pulmonary arteries, the concentration of the carbon dioxide is going to be higher, and the concentration in the alveoli is going to be lower. So this is why we're now able to do that gas exchange, and the carbon dioxide will unload from the blood, from the capillary, into the alveoli where the concentration is lower. All right? So that is what's taking place up here in terms of your external respiration. Then the ventilation perfusion coupling that I talked about, where you want it to be a happy marriage, this is what we're looking at, right? You have really good blood supply coming in, right? So here comes the pulmonary artery delivering that deoxygenated blood to the alveoli. Here we're going to have that membrane between the capillary and the alveoli, and you want it to be a happy marriage, which means we have good blood flow going to that capillary bed, and the blood that is going to be leaving from the alveoli capillary and returning back to the heart through the pulmonary vein, you want that to be a good concentration of oxygen. So this is where you have good perfusion coming to the alveoli, and now we have that nice venous blood from the pulmonary vein leaving the alveoli and then returning back to the heart. So the perfusion, the blood flow to the alveoli is good getting there, and the alveoli and the blood flow leaving the alveoli back to the heart is really good as well. So we have it well matched. Now we have an issue where hypoxemia can develop when we have a low ventilation to perfusion ratio. So what happens here is you could have good airflow coming in, but at the alveoli level, now there's an issue with that ventilation. So if the ventilation is impaired, if there's some kind of issue where that membrane between the capillary and the alveoli is damaged, or it's too thick, or there's a buildup of gunk in the actual alveoli, or something has happened here in the tubing, you're not going to have good air coming in to the actual alveoli. So now we have a problem, right? And so if there's the thickening of the membrane, now we have a problem with the gas exchange. So we're not going to have good unloading of carbon dioxide into the alveoli, and we're not going to have good loading of the oxygen in the alveoli into the actual blood. So here's where we end up having a problem with that ventilation perfusion ratio, and what ends up happening in the blood that returns back to the heart through those pulmonary veins is now you end up with a lower concentration of oxygen and a higher concentration of carbon dioxide, because you weren't able to get rid of what you needed here. This one over here was probably functioning okay, and we had an okay, right? We had a good ventilation perfusion coupling on this side. So over here as well, you can see that if there's a blocked ventilation, right? So now the air didn't even get in to the alveoli. Here we're not going to have any gas exchange, and obviously the concentration of that blood that was passing through here as it came in is going to be leaving pretty much the same, with a high carbon dioxide, very low oxygen. Over here, at least we have something, right? And we had some here, the exchange was actually good, and we had good perfusion. But in both of these cases that you're looking at, if there's impaired ventilation or collapsed alveoli or something happened on this side, you're going to have hypoxemia that can result. So that just means your oxygen concentration in your blood is lower. And remember, so then again, what ends up happening is you end up having less oxygen. So that's going to mean less oxygen for the brain, less oxygen for the other tissues. And then long term, that could obviously be a big problem. So that's what ends up happening, unfortunately, with people that have emphysema. They end up actually damaging the alveoli, and then they're not able to breathe properly, and long term they actually end up succumbing to that actual disease. All right, so then in terms of what happens when we have oxygen, higher oxygen concentration in the alveoli, and how the actual capillary network is going to respond, it's pretty cool. So as what you're seeing here is, so you've got your blood supply, right? So you've delivered the deoxygenated blood coming into the alveoli, and now you've got your capillary network. And what will happen is when you have a high concentration of oxygen in the alveoli, so you have more, right? Then say, for example, you're working out, right? And so you're going to be bringing in more air, right? You're going to have more to load into the blood. What happens is these capillaries actually end up dilating so you can get more blood flow into them and increase the number of red blood cells that are being delivered into the space. And so it's pretty cool because you're doing this You've got more oxygen available, so you can load more oxygen in because now you have more blood flow through the capillary network. And when you think about it, you're also able to unload more carbon dioxide into the alveoli to get rid of it. So what I want you guys to remember about this is when the alveolar oxygen concentration is higher, right, so it's greater in the alveoli, that means that that capillary network, the arterioles, are going to dilate and increase blood flow, which means more perfusion, which means you can load more oxygen in. If you're at rest, right, you're not working out, you're not needing as much oxygen, then when the alveolar concentration decreases, then those arterioles are also going to decrease blood flow, which means they are going to constrict and decrease how much blood flow is actually passing through. So it happens in proportion. Then what happens in terms of our bronchioles, also pretty cool, when we're working out, or if you're more metabolically active, right, you're producing more carbon dioxide. So when you have more carbon dioxide that unloads from the blood into the alveoli, that will then trigger the bronchioles, because remember, those are the tubes that are having this air leave, right? So we want to exhale out the carbon dioxide. They will actually have bronchial dilation, so they dilate to open up and allow for more airflow to leave from the alveoli out into the bronchi and then continue on out so we can exhale it. Now, when you have less carbon dioxide, right, so when you're at rest, you're not producing as much carbon dioxide, so you're not going to unload as much carbon dioxide into the alveoli, and then what will happen is the bronchioles will now constrict, so you'll go through bronchial constriction, and then you'll just have less space, right? The diameter will be smaller and not as much air will be exhaled out because you're not producing as much carbon dioxide. So it's pretty cool how our body is able to regulate with the ventilation perfusion and the coupling that happens based on what our oxygen concentration is with our arterioles and then what the carbon dioxide level is in the alveoli relative to what it is that the bronchioles are going to do. So make sure that you know both of these things because I will be asking you about that on the test. Then your internal respiration, remember this is now referring to what is taking place with the gas exchange from the tissue to the blood and then from the blood down into the tissue. And so when the systemic arterial blood is at a higher concentration with oxygen and the tissue is going to be lower, then we're going to have that diffusion, right? Oxygen will diffuse, it will unload from the capillary into the tissue, and then the blood will then continue, and then the oxygen concentration of the blood returning back to the heart is going to be lower because we unloaded at that tissue level. And then the carbon dioxide level obviously is going to be higher in the tissue. It will load from the tissue into the blood, and then it will travel back to the lungs. And then in the capillaries at the lung level, the carbon dioxide concentration will be higher, and then obviously it will unload. So that is how we're able to do that gas exchange at the tissue level. So remember, with internal respiration, what is happening is oxygen is unloading into the tissue, and then carbon dioxide is loading from the tissue into the blood. How it is that all of this is transported has to do with the structure of the hemoglobin. And back when we talked about blood, we talked about the structure of hemoglobin. So what we have here is we have our chains, which are our alpha and beta chains, and then we have the 4 hemes on the hemoglobin, which is where the oxygen will actually be transported. So the maximum oxygen molecules that can be transported on one hemoglobin molecule is 4. All right, so we have a total of 4. So we have 4 spots to actually go through and load the oxygen. What happens is that it has to do with affinity. And what affinity means is how easily, one, is that oxygen going to get on and off the hemoglobin, but then how is it sticking on, right? Does it come off easily? So what we're looking at when you're loading and unloading, it has to do with the shape of that hemoglobin. So as oxygen binds, what happens is the affinity for the oxygen increases. So it makes it easier for that oxygen to get on. As the oxygen is released, it makes it easier for the oxygen to get off. So it's really cool how this works. When you have 100% saturation, that means that all 4 hemes on the hemoglobin have an oxygen molecule on it, right? You've got your molecular oxygen. When it's partially saturated, it means you may have 1 or 3 oxygen molecules on it, but not all 4 are actually filled. And so what occurs is when you have your systemic arterial blood, your oxygen saturation is going to be on average about 98%. So when you put on the pulse ox on a patient, you're looking at what is the saturation of the hemoglobin. And we are assuming that it's oxygen that is on that hemoglobin, because almost always that is the case, right? But sometimes you're going to have other gases that will get on that hemoglobin, and it can actually indicate an error in terms of you're thinking that, oh, this is oxygen, right? So you could have carbon monoxide on there, you could have more carbon dioxide, right? But most of the time when you put the pulse ox on, you're actually saying, okay, that is hemoglobin that is on. So then you look at your little number and you're like, oh, it's, 98%, 99%. So, and then your venous blood, when the blood is returning back to the heart, remember what you have there is now you have an unloaded, right? You unloaded oxygen into the tissue, you loaded carbon dioxide into the blood, and so the hemoglobin is going to be less saturated on the venous blood side when it's going back to the heart. So when you look at how is it that this works, all right, when we have oxygen, when you have a partial pressure of oxygen that is about 70, all right, so this would be much less obviously than what we have and when we're at sea level, all right, so when you even go to altitude, you are still okay in terms of your saturation on your hemoglobin because you can still saturate pretty well, right, in the mid-90s actually. So it's not going to affect a whole lot more. When you have somebody who has a saturation, say you're at sea level, right, and you've now, I always think of the football teams when they're playing, in LA or San Diego, and they're putting on molecular oxygen, right? They got their O2 tank there and they put the mask on and now they're giving themselves oxygen. They're doing high flow oxygen to try and replenish after having done, a crazy sprint down the field or whatever. And so what cracks me up is that you already have the molecular oxygen available in the air at sea level that you need. And so what they're doing is they're trying to force more oxygen in. But what happens at sea level is that it's not really going to benefit you that much because even if you had a lower partial pressure of oxygen, you'd still be doing pretty okay, especially when you're somebody very, very fit that is training. So it's not going to do that much in terms of helping that person, but it's going to help a tiny bit, but it's not going to be anything huge and significant. So that is what this means by further increases in partial pressure of oxygen produce only a very small increase in the actual binding. So what you're looking at here, this is called the oxyhemoglobin dissociation curve. And what we're talking about is what does oxygen do based on its partial pressure and how does it saturate on the left side here, the hemoglobin. So what you're looking at, here's your partial pressure of oxygen, all right? So at sea level, on average, right, say we have a really high saturation of partial pressure of oxygen. So our hemoglobin, where the partial pressure is high, it'll saturate on the hemoglobin very high, right? So here's our partial pressure down here. We go up, we look at the left, this is our hemoglobin. Wow, really, really good partial pressure of oxygen. Now let's look at what happens when we go to altitude. So say at altitude, the partial pressure of oxygen was down in 80, right? So we're at 80 millimeters of mercury. We are still going to have a pretty good saturation over here with our hemoglobin, even though the partial pressure decreased, right? It's not going to be that bad. Now, when you start dropping, right, so you're going into even more altitude, right? And again, I don't know what it is at Mount Everest, but let's pretend it's here at 50, right? So say the partial pressure of the oxygen at really high altitude is at 50. Well, now here, yeah, your saturations are going to be affected because now with this partial pressure of 50, you go up to see what is the saturation going to be, and you move across, and now you're down in the 80s. Somebody here is going to have a pretty tough time. They probably need oxygen, additional oxygen to breathe from a tank to start raising that up. So that is kind of what this is showing here, all right? Now, when you look at our blood, right, so when you're looking at your arterial blood, right, so our systemic arterial blood, our saturation of oxygen is going to be pretty good, okay? Now we're at rest. So now we delivered the blood to the tissues, and now let's look at what happens to our oxygen saturation. It actually goes down because now we've delivered our oxygen, we have unloaded, and at rest, we will remain with about a 75% saturation once we unload into that resting tissue the oxygen that it needs. So that is why right here, when you look at what happens with deoxygenated blood, right, because we unloaded it into the tissue, now our concentration of oxygen is going to be much less. When you're working out, that changes, right? Now you're going to have an even bigger change. So here's kind of what happens. So when we're at rest, we unload the oxygen. The venous blood is now going to have a lower saturation. When you're working out, you unload even more oxygen because your oxygen demand for that exercising tissue, say skeletal muscle, is going to be much, much greater. So now what happens is you go here. We have now unloaded more oxygen into the tissue, and now your concentration is going to be much less because now the partial pressure of the oxygen that remains in the blood is much greater. All right. So all this is showing you is what happens at the different partial pressures of oxygen to the actual saturation of your hemoglobin. All right. So here, pretend that this is your arterial blood, right? So this is where we have our systemic arterial blood. We have really good saturation. We are now delivering it to the tissues. At rest, we unload. Now we're going to have a lower saturation of oxygen because at rest, once we unload that oxygen into the tissue, our saturation is going to be about 75% because now the partial pressure of that blood that is now leaving the tissue with the oxygen is going to be around 40, right? Because we unloaded oxygen and now our saturation is less. When you're working out, that changes even more because you end up unloading even more oxygen. So now the partial pressure of the oxygen that remains in the blood as it's being transported back to the alveoli, right, is going to be much less because you unloaded more oxygen when you're working out. And so that's why your partial pressure when you work out actually decreases more in that blood as it's returning back to the heart. And then obviously the saturation would be much less. And so that's what ends up happening with this oxyhemoglobin curve. And then why this matters is when you're looking at metabolic activity. All right. So what you see here is what happens when you're more metabolically active. So what we're looking at is this is our normal. So this pink one here. All right. And what you're seeing here, this is not equating to what happens with pH. All right. Sometimes students look at this and like, oh, blue and red, right? Or blue and pink. No, we're not talking at all about what the pH scale is doing here. We will talk about pH, but this is not your pH scale. All right. This is still the oxyhemoglobin dissociation curve. And so this right here, this is your normal. All right. So this is what happens at normal levels. So this is when you're healthy. This is when you're not at altitude. This is when you're just at rest. So the extremes that they have put on here, and a lot of authors will do this, is they will show you, okay, well, what happens when you are sick, right? When your temperature goes up, and when you're working out, maybe you become more acidic, or you're diabetic and your blood becomes more acidic. So what's going to happen? So we're going to have some real crazy extremes of what you're looking at here. So first, let me talk about this rate of unloading and loading that is regulated based on partial pressure of oxygen, temperature, the pH of the blood, so how acidic or how alkalinic you are, and remember that pH will also be impacted by what happens with the concentration of carbon dioxide in the blood. So what happens when you have a fever, right? So say you're sick. So when you're sick, you're going to have greater glucose metabolism, right? Your body's going to be more active because your body is trying to help you get better. So metabolically, you're more active. Your fever, right? Fever is going to go up. So let me just kind of go back to this picture here. Okay. So what happens here when you have a temperature, in this case, it will actually increase, and that will cause this oxyhemoglobin dissociation curve to shift to the right, right? Because what happens when you have a fever, you are more metabolically active. The other thing that happens, for example, when you're working out, yes, your body temperature goes up a little bit, but remember that you're also now using more energy. You're going to be metabolizing more nutrients. So glucose metabolism will also go up. Even if you're using fat, you're metabolically more active, right? And so what's going to occur is when you have a shift to the right, what happens is that you're actually causing the affinity for oxygen to decrease. So when it shifts right, that means that you're not going to load as much oxygen up at the alveoli level, but it's going to be easier for the oxygen to get off, right? So with the affinity decreasing, right, so when you have a right shift on the curve, that means the affinity for oxygen decreases, which means it's easier for it to unload into the tissue. So when you think about what's going on when you're working out, right? You work out, you're producing more carbon dioxide, and you also can cause your blood to become more acidic because of the carbon dioxide. If you have metabolic acidosis going on, say you're a type 1 diabetic, right? Your blood becomes more acidic. That is a stress. So I always kind of used to think about this as I was first learning about this hemoglobin dissociation curve, is stressful situations, okay? You are exercising, sympathetic. You have a fever, your body will become more sympathetic when that happens. Or you're sick and you're producing more acid, right? Whether it's more carbon dioxide production that is causing more acid production from the carbonic acid, or you're working out and you're producing more lactic acid. All those things are going to cause a right shift, right? So if on the registry exam, and then on the exam I'm going to be testing you on, I'm going to be asking about what happens when glucose metabolism increases, right? Boom, you're producing more carbon dioxide. You're producing probably more lactic acid. All those things are going to cause right shifts on this oxyhemoglobin dissociation curve. So what you see happen is that shift is going to be more to the right. Now, when you're less metabolically active, right, say your body temperature gets colder, you are more basic, okay, you're in more of an alkalosis state. All those things are now going to shift the curve to the left. So now what happens is when glucose metabolism decreases, now it shifts everything to the left side. So what you're looking at here in terms of body temperature, right, this is a real extreme here. So if somebody had a body temperature of 43 degrees centigrade, this is like 109, all right? Over here at 10 degrees centigrade, this is like 59, right? So you'd be dead in those two extremes. But again, they're looking to give you the example of what happens with stressful situations, right? Or when the homeostasis gets messed up. When everything's normal, happy, good. But when we start now becoming more acidic, warmer, and oxidizing more glucose, it's going to do a right shift. So it'll shift to the right. It'll decrease the affinity for oxygen, which means you will have less oxygen loading, but the oxygen that you do load will unload more easily. All right, and that's okay. Now when you have a decrease in glucose metabolism, which means you're now colder, so say you're becoming hypothermic, right? Your body is going to decrease the amount of metabolic activity in the whole body to keep you warmer, all right? It's going to start shutting things down and decreasing activity so that the blood will shunt to the core, and it's going to start slowing down your metabolism because we need to preserve heart and brain function, right? And so now what's going to happen is we're now going to shift to the left. So now the affinity for oxygen increases, but what that means is that it makes it harder for that oxygen to unload. But remember, you are less metabolically active. So your demand for oxygen when you are less metabolically active actually decreases, and that is why this also shifts to the left. So, bottom line, easy way to remember this. A right shift in the oxyhemoglobin dissociation curve will occur when you are more metabolically active, you're burning more glucose, you are warmer, body temperature is going up, when you're sick, when you have a fever, and also when you're working out. Now, it's not going to shift this far over when you're working out, but it'll shift slightly to the right. Then, when you're less metabolically active, when you are colder, when you are not using as much energy, all right, now we're going to shift to the left. So it would shift to the left also when you're becoming more basic. So that is what these this oxyhemoglobin dissociation curve is referring to, and how your body actually ends up adapting to what's going to happen with how easily is it going to unload the oxygen based on what your metabolic demand is going to be. And so I love this because our body's able to adapt with that. Then carbon dioxide, the way that it's transported in our blood, the majority of it is dissolved in the plasma in the form of bicarbonate. Any carbon dioxide that binds to our actual hemoglobin is now going to be called this big word, you've seen it before, it's called carbaminohemoglobin. So this is bound carbon dioxide on the hemoglobin. You will bind more carbon dioxide on hemoglobin when you unload more oxygen. So when you're doing a tough cardio workout, you're actually unloading more oxygen and loading more carbon dioxide on hemoglobin because you're transporting more. You're producing more carbon dioxide in the tissue, you're then able to transport more carbon dioxide on the hemoglobin. Right? So that's kind of a cool thing that our body can do. But the majority of the carbon dioxide, whether you're working out, whether you're at rest, most of it is going to be dissolved in the form of bicarbonate. All right? So there's a CO2 in here. So what happens, and back to this when I've talked about the transport and exchange of carbon dioxide and how it affects the transport in the blood, is that it takes place, a lot of this reaction, what you're seeing here, this chemistry, is going to take place on the red blood cell, because a red blood cell has an enzyme that is very, very important. It is called carbonic anhydrase, CAH, all right? And so what this does is that it catalyzes the reaction that is going to occur between carbon dioxide and water and forming carbonic acid. So the enzyme takes place right here. So let me just show you what occurs. So when our body is we're working out, right? So let's pretend that this tissue here is muscle, right? Skeletal muscle. We're doing a really hard workout. So what's going to happen is our body is going to produce more carbon dioxide and water. And where you see these big arrows, all right, this is what's happening primarily on the red blood cell. So carbon dioxide is going to load from the tissue onto the red blood cell. What's going to happen there is the water, right? We also produce water. These two are going to come together, and very quickly the reaction will happen because of the carbonic anhydrase enzyme that is on the red blood cell. It will form carbonic acid. This carbonic acid will then dissociate into bicarbonate and hydrogen ion. What will happen then is this bicarbonate is going to go into the blood plasma, the plasma fluid, and chloride from the plasma fluid is going to come and go onto that red blood cell. This right here is called a chloride shift, and it is a very important thing that our body is able to do on our red blood cells. This also happens in our kidney cells, and it also happens in our digestive tract. So our tissue cells are able to do this as well. But on the red blood cell, because we have this enzyme, we're able to make this carbonic acid very quickly and then dissociate into the bicarb and this hydrogen ion. Bicarb goes in to our blood plasma because we need to have this bicarb in there. We need a bicarb reserve. And then chloride, best friends with bicarb, actually just trades places and says, no worries, I'll hold your spot on this red blood cell. So this is where, when this hydrogen here is now bound on the hemoglobin, this is where you get this HHB. And you guys have seen this, and we call this deoxyhemoglobin, right? Because there's no oxygen on here. Well, how did that happen? Well, when we had HbO2, this is what happens at the level where the lung, right, the oxygen that we have in the alveoli loads onto the red blood cell. This is where we get HbO2. This is oxyhemoglobin. When we get down to the tissue level, remember, we have a higher concentration of oxygen on the red blood cell relative to what's in the tissue. So the oxygen is going to unload, so it unloads from that red blood cell and diffuses across onto the tissue. So we have carbon dioxide loading onto the red blood cell, oxygen unloading and going into the tissue. And so when this oxygen unloads, it gives up a spot, right, on that hemoglobin. And so what is happening is you will have some of that CO2 will be in the form here of carbon dioxide on the hemoglobin, and some of that hemoglobin, parts of it, will also have a hydrogen ion that will then be kind of babysat on the hemoglobin itself, and now we have deoxyhemoglobin. So this is what happens at the tissue level. Then we go back to the lungs. So at the lungs, now we want to exhale out the carbon dioxide. So how we do that is now we have the reaction happen in reverse. So the chloride shift will happen in reverse now. We'll have bicarb come back onto the red blood cell. The chloride ion will leave, so they'll shift through their little port. The hydrogen ion will get off that HHB, right, off the hemoglobin, and it will meet up again with the bicarb. These two will come together, they'll form carbonic acid again, and then very quickly the carbonic anhydrase will cause it to return to its normal products from before, water and CO2. And so now we exhale carbon dioxide and water into the alveoli, and then this carbon dioxide that ends up in the alveoli, obviously some of it will travel through the tubing out, and then you will exhale it out in the air that you exhale. The oxygen that is in the alveoli will load because you have a higher concentration of oxygen in the alveoli, so it'll load onto the red blood cell, and then when it loads onto the red blood cell, that's when it displaces that hydrogen, and then it binds to the hemoglobin, and then we have oxyhemoglobin. And so this happens every single time you have this little red blood cell passing through the alveoli. If you have good perfusion, we'll have this gas exchange happen. And so where you see these arrows, they're the big arrows. What is happening is, what I want you to understand is this reaction primarily takes place on the red blood cell because we have this carbonic anhydrase enzyme. You will have a slow reaction that will happen. You know, same thing, hydrogen plus bicarb makes the carbonic acid, then it'll go back to carbon dioxide and water, and then you'll exhale it out. You will have some CO2 that's dissolved in plasma just as a pure gas dissolve across. That's normal too. You will have some oxygen that loads from the alveoli and just goes into the blood plasma. Very little of it will actually just be in as I call it the oxygen bubble, in the actual alveoli. All right. But the big thing that is taking place with this loading and unloading is because of this carbonic anhydrase that we have. Some of that carbon dioxide that was in the form of carbaminohemoglobin, right, that will also diffuse off because we have more carbon dioxide here and less in here, so it comes off. So that is what is taking place between your internal respiration and your external respiration. Then at the tissue level, this thing that's called the Haldane effect, all that means is that as the oxygen unloads from the hemoglobin into the tissue, then carbon dioxide can easily form carbaminohemoglobin because oxygen gave up a spot on the hemoglobin, and now that CO2 can actually bind onto the actual hemoglobin. And so when you're producing more carbon dioxide at the tissue level, as that oxygen unloads, you can actually have more carbon dioxide go on the hemoglobin. So that is what's referring to with the Haldane effect. So as more CO2 enters the blood, more oxygen dissociates from the hemoglobin, so that's your Bohr, and then the Haldane piece is you can actually load more carbon dioxide onto the hemoglobin, right, based on how much O2 ended up getting off. So how much CO2 is transported on hemoglobin is going to be affected by how much oxygen was transported down into that tissue level. So pretty cool. It just has to do with, just think of it as, hey, the seat opened, I can now put a carbon dioxide on there because oxygen took it off, came off and then went into the tissue. Then the alkaline reserve, this is a very important thing that happens in our body because bicarb is our biggest buffer, all right? This is our number one buffer that we have in our plasma because we are not only producing carbonic acid, right, from what happens with CO2 and water at the tissue level, but we have other things that we make that are acidic, right? Lactic acid from working out. We can metabolize fatty acids for energy. We can metabolize amino acids for energy. Those are acids. When you drink alcohol, right, ethanol, your body will go through a metabolic process in the liver and you will produce acetic acid from that. That is one of the byproducts from that. We also have phosphoric acid that we produce, for example, in our kidneys when we go through and we are metabolizing hydrogen ion with phosphate. So there's a number of other acids, metabolic acids that our body produces that we need this bicarb to help bind it. And so what happens is, as hydrogen ion concentration in our blood is increasing from whatever acid, right? It could have been because we had more carbonic acid or we had more lactic acid. This reserve, this extra bank of bicarb that we have, is able to buffer it. And so when the bicarb and the hydrogen ion come together, they form that carbonic acid. And what's really cool is then at the lung level, that is where we can make that reaction happen much faster, and we can actually decrease acidity in our blood by using our lungs. We also do this in our kidneys, but our lungs are able to very quickly be able to cope with hydrogen ion increases that happen in our blood because of their ability to bind with this bicarb, and then doing that really quick reaction that we did here, where we have the reverse, right? We have the bicarb here. So you had hydrogen ion out here that, we have to take care of, right? And so we're able to take care of that hydrogen ion, bind it to the bicarb, and then here form the carbonic acid, and then very quickly, and then also be able to exhale water and CO2, and then boom, get rid of it. So it's a really cool thing that our body is able to do. So no matter where this hydrogen ion came from, right, we can buffer with bicarb, and then at the lung level, make carbonic acid, put it back into water and CO2, and then exhale it out. So that is how you're able to reduce acidity. Then with the CO2 that is produced in our tissues again, right, that got transported back to the lung, boom, then we're able to get rid of that excess CO2 by diffusing it out, either when it's bound on as carbaminohemoglobin, or by doing the chloride shift, where bicarb comes back on to the red blood cell, binds to the hydrogen ion that was basically being babysat by the red blood cell, form the carbonic acid, and then very quickly through carbonic anhydrase, go back, CO2 and water, and then exhale that out. So our lungs are really quick in helping us deal with acid. Then remember again that when it comes to acidosis and alkalosis, we have the two types, respiratory and metabolic. So I again wanted to review these two so to make sure that you're getting this down, because we're going to talk about it again when we talk about the kidneys and when we talk about the digestive system. So remember that blood has that 7.35 to 7.45 is our normal, right? So that is what we base this acidity and alkalinity in our blood. So respiratory acidosis, remember, is caused by high concentrations of carbon dioxide levels in our blood. So we produce more carbonic acid, right? And so that's what increases the acidity. So when you put on the end tidal and you have an end tidal that is greater than 45, right? So if the problem is a respiratory issue, so they have labored breathing, shallow breathing, not breathing, apnea, dyspnea, all these things that are causing irregular breathing, right? Those are going to end up causing respiratory acidosis because the problem is respiratory. So you would have a high end tidal greater than 45 and a lower pH. Metabolic acidosis, this is acidosis that is caused by hydrogen ion that is being produced by something other than carbon dioxide making with water the carbonic acid. So this is not a CO2 issue. The primary cause of metabolic acidosis in people is going to be that fatty acid metabolism, and where you're going to see it most often is going to be in those type 1 diabetics. But it can happen in people who have severe diarrhea that are losing a lot of fluid and bicarb out their butt. All right, that will cause this metabolic acidosis. So the indicator for that and what they do at the hospital is they will measure bicarb levels in addition to pH. But if somebody is in metabolic acidosis and you put the end tidal on, you would very likely see a high level of, on the end tidal, it would show greater than 45 millimeters of mercury, because remember, our respiratory system is able to help you cope with acidity in your blood by getting rid of it. And so you get rid of it, again, back to this picture, is by, we combine that hydrogen ion to bicarb, make the carbonic acid, and then exhale. So you're exhaling more CO2 because you're binding more of this hydrogen ion that maybe came from fatty acid metabolism, and this CO2 level continues to go up in addition to this water vapor. This water vapor is what's containing that hydrogen ion, and you're exhaling these Now you put it in the blood, in the alveoli from the blood, and you exhale that excess CO2, that end tidal is going to show higher. All right? And so remember that your metabolic acidosis is the problem from something other than the respiratory issue. So if you get scenario questions that are asking about are they in respiratory acidosis or are they in metabolic acidosis, remember if the cause of the problem was respiratory, it's respiratory acidosis. If the cause of the problem was something other than respiratory, so it was a metabolic issue, that is what's going to cause metabolic acidosis. Then our respiratory alkalosis, remember the number one cause for this is going to be hyperventilation. So if they're hyperventilating, now you've blown out too much carbon dioxide, your end tidal is going to show less than 35, right? So now your end tidal, you're exhaling less carbon dioxide because your concentration of carbon dioxide in the blood is less. So if you hyperventilate, that is when you're going to see this when it's a respiratory issue. The pH would be greater. Now we have metabolic alkalosis. Now we have an alkalosis that is caused by something other than I hyperventilated. So hyperventilation was not the problem here. Now we have an issue where now we have too much base in the blood, not enough acid. So usually the cause for this, vomiting, right? Because when you vomit, you're vomiting out acid, right? And so, or you've taken too many antacids, or you're taking too many proton blockers, like say somebody that's having an issue with ulcers, and now they take too much antacid or too much of that medication, it blocks too many of the hydrogen pumps, that could cause metabolic alkalosis. Or somebody is drinking stuff that has a very high bicarb concentration to delay an anaerobic threshold from happening. So that could cause this metabolic alkalosis. But more commonly, what will cause this is going to be that vomiting, all right? Because now you've puked out too much acid, and now you have too much bicarb. All right, then in terms of our control of our breathing, right, is going to be controlled by the medulla oblongata and the pons. So in our pons, we have this thing that's called the pneumotaxic area, and this is kind of the thing that helps smooth out when you inhale and exhale so that it's not choppy. So we're going to have our neural regulation, which is here, and then the non-neural regulation, these are going to be your physical and chemical factors. So your physical factors are obviously going to come down to how healthy you are, how healthy your lungs are, how healthy your diaphragm, your intercostals, right? How well can you move those through? And then chemical is going to be your concentration of your gases, right? CO2 and water, or CO2 and oxygen, your hydrogen ion, your carbon dioxide levels, your bicarb levels. These are going to be your non-neural regulatory factors. So what we have is, again, the pons. This is going to be the pneumotaxic center that smooth out the respiratory rate. And then the medulla oblongata, remember when I talked about that your respiratory center is in your medulla oblongata, and this is why it's really serious when somebody has a high cervical injury, because it can actually end up affecting the respiratory center. And anything that ends up affecting respiratory rate, like a drug, right, that causes respiratory depression is going to end up affecting this. So what we have is we're going to have signals, right, coming to the brainstem. So those are your afferent impulses or sensory signals that are going to come in, and that brainstem is going to receive information. Then based on the information that you receive, then that is going to send out a signal through the motor fibers that are going to then tell the diaphragm and the intercostal muscles, this is what you have to do, right? And so we're going to have information that is going to come from chemicals, CO2, hydrogen ion, and it's going to bring info here to the chemoreceptors that will receive that. We will also have information from receptors like baroreceptors and oxygen receptors that we have in our carotid arteries and also in our medulla oblongata based on, hey, what is going on with our oxygen saturation? So this would be more of a hypoxic, right? So if oxygen drops and if it gets low enough, then that's going to send the signal, hey, you need to start increasing your respiratory rate. But normally, remember, CO2 is the primary stimulus for our respiratory rate. So we have this thing in our medulla oblongata that's called the dorsal respiratory group. So that's the one back here in the posterior. This is what I call the dirty blood sensor. So it starts with a D. It's your dorsal respiratory group. This is the one that's going to integrate information from our stretch receptors, right? So how stretched are the lungs and the chest, and also what is happening with the chemoreceptors, the hydrogen ion, carbon dioxide levels. Those will then send out a signal to the intercostals and the diaphragm to increase that respiratory rate. Then the ventral respiratory group, this is the one that is now going to send out that signal that is going to say, hey, now you need to increase your respiratory rate. So that's why it's called the VRG, right? Ventral respiratory group. So when you have eupnea, eupnea means normal. This is 12 to 20 in adults, right? So 12 to 20 is normal respiratory rate. If you have what's called tachypnea or hyperpnea, that means you're breathing faster. This is an accelerated respiratory rate. And if you have bradypnea, that means it's lower. So based on what is coming in from our DRG, right, our stretch receptors and our chemoreceptors, that signal comes in. It tells that dorsal respiratory group, hey, we need to either increase or decrease our respiratory rate. And then the signal goes out from the ventral and then off it goes. So this ventral respiratory group is your pacemaker for your respiratory rate and how often, right? How often you're going to be inhaling and exhaling. And then also remember this ties in to what is taking place here with the pneumotaxic center that is going to determine how smooth that in and out is going to be. And so that is how that is regulated. And then our non-neural factors, remember, these are going to be things that, like physical factors, obviously they're going to affect how much we're breathing, is going to be exercise, talking, coughing, right? And then conscious control, right? How deep we're breathing or how hard we're exhaling. And then emotional factors, right? When you get scared, when you get angry, when you get excited. Obviously, these things are more sympathetic type responses. And so remember that sympathetic type responses are always going to increase our respiratory rate as well. Then CO2 levels, again, remember that your CO2 levels are the most important stimulus for breathing. So this is what's going to determine how fast or how slow we are breathing. Our oxygen levels, changes in the partial pressure of oxygen concentration. We do have chemoreceptors for that in the aorta and the common carotid arteries, but our primary stimulus is still going to be the carbon dioxide levels. Our oxygen levels, or partial pressure of oxygen, doesn't become the stimulus, or what we call the hypoxic drive, until our O2 levels drop low enough to then stimulate that hypoxic drive. And people who have emphysema and chronic bronchitis with COPD, they're going to be the ones that are going to tend to have more of this hypoxic drive driving the respiratory rate. So when you're giving oxygen to somebody that is having, that is in a hypoxic state, but they have emphysema and or bronchitis, what happens there is that you need to obviously monitor and be real intentional about making sure that you're keeping an eye on what is happening to the respiratory rate and then their O2 saturation, right? And then also keep an eye on your end tidal, because that is going to tell you a lot about how is my patient doing. And hopefully they're conscious, they're talking, and you're able to carry on a conversation with them that is going to give you a very good indicator of how they are. Because the last thing you want to do with these individuals is cause the concentration of oxygen in their blood to get too high, and now you've actually impacted the thing that is the stimulus for their breathing. Now, in short transports here in the city in Phoenix, they're going to be short. You're probably not going to see a big issue with this. But if you had a longer transport, that is when you would end up probably having to monitor this more closely. And ideally, hopefully, you would have a ventilator if you're having to do a very long transport for somebody. And then hyperventilation, remember what happens here is your CO2 levels drop too low. And so what our body will do when CO2 starts to increase, obviously it increases our respiratory rate, but it doesn't necessarily mean that you're going to go into this hyperventilated state where you're like, right? That's hyperventilation. But all this is referring to is that when your CO2 levels start to increase, that will stimulate that respiratory center to increase respiratory rate. If somebody hyperventilates, right, it can result in this hypocapnia. So hypocapnia just means when your CO2 levels are below what normal is, so below 35. And so hypocapnia means low CO2 concentration in the blood. Hypercapnia would be high concentration in the blood. And so when somebody hypoventilates, that can cause CO2 levels to increase in the blood, right? And then your CO2 level would be higher. But what happens when somebody is hyperventilating and they become hypocapnic, what the body will do is it'll decrease the respiratory rate. In some cases, it can actually cause it to stop, which is why it's so dangerous to hyperventilate, even as a game. Because what happens with hyperventilation is your respiratory rate will decrease, so you'll start hypoventilating, right? It's the opposite of hyperventilating. And what your body is doing is it's trying to accumulate carbon dioxide so that you will make more carbonic acid and increase the acidity of your blood and bring down that pH. But the other big risk when somebody is hyperventilated is that what it does to the brain is that it causes constriction of those cerebral arteries. And when you constrict the cerebral arteries, what you're also doing is you're decreasing blood flow to the tissue. So perfusion of the brain actually suffers, and your cerebral perfusion pressure goes down, which means now your brain is getting less oxygen, right? So that is very, very dangerous. We don't want that to happen. So arterial pH, remember, it can become acidic, whether it's a CO2 retention or something is accumulating from another acid. So lactic acid can do that, excess ketone bodies, which is what results from fatty acid metabolism, and it's going to be your type 1 diabetics that have type 1 diabetes mellitus, or your insulin-dependent diabetics. That will start causing the increase. It'll stimulate the respiratory rate. So increasing hydrogen ion in the blood or increasing CO2 levels in the blood, those will also stimulate your respiratory rate to increase. And then again, I've talked about a little bit on emphysema and COPD. So remember that this is going to cause dyspnea. Usually people that have had chronic bronchitis and emphysema have a history of smoking. The majority of them do, but not everybody that has COPD was a smoker. They may have been around it, or they lived in a place that had a lot of pollution, or they were exposed to a lot of chemicals in the job. But either way, it causes dyspnea, right? So you'll have a lot of coughing, frequent pulmonary infections, because again, that tissue lining has been compromised, and then they're not able to deal with toxins or bacteria and viruses that get in. But these individuals are going to be hypoxic. They're going to retain more carbon dioxide. They're going to be more hypercapnic, and they will live in more of a state of acidosis, all right? With chronic bronchitis, the thing that I want you to remember here is that there's a lot of lower respiratory mucosal inflammation. So the actual tubing becomes more inflamed and there's excess mucus there, which causes an impairment in ability to ventilate, so move air in and out. And then obviously the gas exchange will suffer because you can't get the right concentrations in of the oxygen and you can't get the right concentration of carbon dioxide out. So these individuals do live in a chronic hypoxic state. The patient itself will present as more cyanotic, and obviously they will be more hypercapnic. They will retain more CO2. So these individuals tend to have more of a bluish tone to their skin, to their lips, to their nail beds, and again, in their gums. And this is more the chronic bronchitis, more inflamed bronchioles and bronchi. And then with your emphysema, this is where you're going to have individuals where the alveoli itself is more damaged. So they're usually stretched out, so they've lost a lot of elasticity and they have a much harder time exhaling, and there's a lot more fibrosis. So what happens is that it takes them longer to exhale, and some of the air is going to remain trapped. So these individuals actually tend to present more with more of a barrel chest, but their actual capillary fill, their gums, if they're lighter skinned, their skins will be more pink, and their actual gums and stuff, again, like I said, will be actually more pinkish, more reddish. So what will happen here is that they won't present as much in cyanosis. Cyanosis actually occurs more in later stage disease state, but they will have that distinctive kind of barrel chest, because what happens is they're now holding more air in their lungs because they're not able to exhale as much of it out. And so that is what happens primarily with emphysema. And then here's just that picture that you'll see, and this is what I mean by hypertrophied alveoli. Air stays trapped in here, and in some cases too, they're going to have that issue with what ends up happening in the bronchi and in the bronchioles. And then this is a perfect example of what you'll see with somebody who used to smoke that has actually now had damage to the actual tissue. So now your surface area for your alveoli is actually decreased, because you can see all these holes. This is all just damaged lung tissue. And real sad way to die. And then the pathogenesis, again, when you look at this as a whole, with your chronic bronchitis, you have more excessive mucus production. Normally they'll have a chronic cough, but it'll become gooey and gooey. Ugh. And then with the emphysema, now you have more of that destruction of the alveolar tissue, loss of lung elasticity, and in the end, respiratory failure will be what ends up causing the issue. The individuals that have this COPD, they're going to be oftentimes on diuretics, they're going to be on vasodilators, they're going to be on a lot of steroids to try and reduce some of that inflammation that happens. But eventually they will succumb to the disease because they just simply cannot oxygenate in a way that is going to be able to keep them alive. Then, as far as some other respiratory disorders, asthma is more of a reactive airway disease, and so this triggers a bronchospasm. Oftentimes, this is going to be more of an inflammatory response that is mediated through the immune system. So this is kind of like an allergic response, what happens with asthma. And so what will occur is you'll have this inflammation that happens in the bronchioles, and they're hypersensitive. So you'll get an allergen that comes in, and then it starts, what they'll start doing is they'll start chronically coughing and not be able to take a proper breath in, but then the air will stay trapped. And so they'll have a lot of dyspnea, coughing, and then the wheezing is your big telltale sign that you have this obstruction that is occurring in those passages. And you'll hear the wheezing with the vesicular sounds and also the wheezing with the bronchial sounds. So with individuals that are having this issue, a nebulizer is always helpful, right? So albuterol, super helpful, but you want to do that mix of the albuterol and the Atrovent to try and open up those airways. And then epinephrine obviously is helpful for this as well. If you can't get a result from the nebulizers, and then sometimes mag sulfate, given the mag is going to help, so magnesium sulfate. And then epinephrine, again, like I said, would be something that would be your big kind of last resort if you're not having a positive result. In some cases, asthmatics do need to be intubated, because if you're not getting anything and you're going to have a longer transport, in this case, you may have to intubate the individuals. And then lung cancer, something that's very important for you guys to understand is, so you can have like what's called an adenocarcinoma. So these are going to be tumors, obviously, in the lungs, squamous cell carcinoma, and then what's called small cell carcinoma. So what I want you guys to keep in mind with this, most of the lung cancers tend to be this adenocarcinoma, and this will be more along the bronchial glands and then your alveolar cells. But the one that can happen that starts presenting as a hypercalcemia is when you have the squamous cell carcinoma. So if you are ever told that you are hypercalcemic, please get a chest x-ray, because sometimes what is happening is that you have these tumors that are producing PTH. And remember that parathyroid hormone is what targets the bone, the osteoclast, to start dissolving bone and then bringing calcium into the blood. And it can cause you to become hypercalcemic. So hypercalcemia sometimes can be indicative of a squamous cell carcinoma. And then small cell carcinoma, what can happen here is it can actually mimic ACTH and ADH. If it's ACTH, remember that ACTH targets the adrenal cortex. This is adrenocorticotropic hormone, and it actually targets the adrenal cortex to start producing more aldosterone and cortisol. And so what can happen here is that the person will have hypernatremia, so you'll have high levels of sodium, because that's what aldosterone does. It helps retain your sodium. And you'll also have high levels of cortisol, which can also present as having hyperglycemia or high blood sugar. So if you have hypernatremia and hyperglycemia, that could be indicative of a tumor that is causing this increased ACTH production. And then ADH, of course, is antidiuretic hormone, which increases blood pressure and then also increases fluid retention. So that could happen from the small cell carcinoma. So this is why these respiratory disorders can sometimes present as other things, but it ends up being that it's an issue and it's a cancer in the lung. So these are pretty insidious, these lung cancers. And then developmentally, just remember the lungs in babies don't really fully inflate until 2 weeks after birth. If you have a preemie and you're going to be delivering in the field and it's a preemie birth, please remember that it's very likely that these babies are not going to have the ability to breathe on their own, so be ready for that. One of the things that happens is that their lungs are not fully developed, which also means that they don't have enough surfactant, which is the chemical that helps prevent the alveoli from sticking together and collapsing. So you don't want that to happen. And so surfactant is going to be formed later in the pregnancy, but it takes a while for that surfactant level to build up enough in order for those lungs to be viable. So this is why a lot of times babies in the NICU are actually on ventilators, because they're waiting for that lung to fully develop and be able to breathe on their own, or they can't leave the NICU. And then as you get older, your respiratory rate decreases. So newborns, normal respiratory rates for them are 40 to 60. Infants, after the age of 1 month, that's where you kind of fall into that infant rates, around average around 30. And then from age 5 to 25, right? So you're going to have your elementary age school kids, and you'll have your preteens and then your teens. So as you get into those school age years, they'll range on average 25 breaths per minute. And then once you get into adulthood or late adolescence, that's when you're in the 12 to 20 rate. And then they'll start to increase a little bit more as you get into older age, depending on, lung disease and other issues that have occurred with the individual. So, but you'll go through the lifespan chapter in the EMS book, and you'll learn a lot more there, obviously, about, respiratory rates, blood pressure rates, heart rates. And then when you go into the individual actual chapters where you're leading with pediatrics and then dealing with geriatric populations, they'll talk again about this. So, but make it a point to learn what these on average bottom numbers are. So like with newborns, 40, infants, 30, with age 5, on average school age around 25, and then with adults, right, late adolescence to adulthood, 12 to 20. Because this is going to help you in terms of when you're assessing peds, where should this respiratory rate be? And if you're looking at a respiratory rate of a pediatric patient that, say, is a year old and they're at 12, that's not high enough, right? Little, 3-year-old, 4-year-old should be up in that 20s, right? 25 to 30 breaths per minute. And then youth and middle age, obviously, respiratory system infections can be the cause of cardiac arrest, because usually when you have kids that decompensate, oftentimes it's an issue that either happened with disease or with a respiratory issue. So the respiratory system usually is going to suffer there from colds, infections, right, different viruses that can actually physically block the passageways, or you can have an anaphylactic issue that ends up blocking the glottis. And then in terms of aging, remember, as you get older, the elasticity of the lungs is going to decrease. Vital capacity decreases, which affects your ability to inhale and exhale air. So your maximum inhale, maximum exhale. And then oxygen levels can also decrease based on disease, or the person's, they become anemic. And then carbon dioxide levels as you age, the stimulus for that center to continue, to modulate and regulate your respiratory rate can be affected. And then elderly, remember, you can end up having problems with sleep apnea, where people actually stop breathing, right, because something occurs. They just, with their tongue, or they have obstruction in the nose or the pharynx. So that is why sometimes you're going to have to get on CPAP. So obviously as you age, there will be more complications, but normally when a child goes into cardiac arrest, it's often because there was a respiratory issue or some kind of infection. Their hearts aren't jacked up and screwed up like, they are with older adults, because we've lived a long life, right? And we've done things to them over time as we've aged. So, but just keep these things in mind. You'll learn more about these as you go through the respiratory emergencies, and then when you get to the actual chapters that are dealing with the different populations. So that's it for the respiratory chapter. Lots of information in here, but obviously very important. And again, reach out to me if you have any questions. If you need me to cover anything, we can always jump on a Zoom and do that. And we will move on now to the next chapter.